with FPSM, and we will not try gallium again. Gallium is too costly.
What's the role of PSMA PET scan in primary evaluation? As Dr. Chandra explained, that MRI is the modality of choice. It's explaining everything. So what's the role in primary only?
See, in primary, I'm telling you, like where there is an MR negative and still a clinical FPSM, do a, like if the uptake is very high in the upfront, nodal and M leave it. If that is positive, obviously nothing to do. We can straight away say that it is a primary prostatic malignancy. Then, in case you find a little heterogeneous or you still have a suspicion with high, because that is where the clinician would come into picture, because as per the guidelines, it is not recommended upfront. So if there is a high clinical suspicion, do a digit scan at 3 hours. If the focality picks up, go back to the MR, check anything that is still suspicion on the MR. If it is, go for a biopsy. If it is, then a clinician falls. Generally, PSMA focality is not negative. Generally, focality is not negative. So predictive value towards those lesions is high. I don't have that much of feedback because I don't go back and ask the MR, because most of them are done outside. So upfront, we are finding a lot of patients now who are being recommended straight away for FPSM, and then we have been always talking. So once you gain the confidence of your clinicians, you yourself will be high on confidence, and then probably those nodal and M will be obviously M, so there's nothing to talk about. Nodal, yes, I've shown you enough scans with upfront as well as on the recurrent. So it's just a matter of time. You click with your urologist, oncologist, and let them have a taste of it. Then probably they'll like it. Hopefully.
Thank you, sir. We're running short of time.
Yeah.
So
Okay.
Thanks a lot.
Thank you.
Anybody ask a question, you can come back here.
I request our chairpersons to please felicitate our speaker. I also request Dr. Avdesh Pandey and Dr. Puneet Bhutani to come on stage to felicitate our chairpersons, please. Ashok Goel. Dr. Ravinder Sidhu. Dr. Avreen Singh Shah. Thank you all. Moving on to the third session, prostate cancer treatment option depends on several factors such as how fast the cancer is growing, whether it has spread, and overall health, as well as the potential benefits or side effects of the treatment. Understanding one such treatment option is surgery. Our next session is recent advances in surgery for prostate cancer. I request the following doctors as chairperson to please come on the stage. Dr. Jaspal Singh, Professor and Head, Department of Surgery, DMCH. Dr. Manjeet Jora, Radiation Oncologist. Dr. Anand Sehgal, Urologist, Deep Hospital. Dr. Sunandan Sharma, Surgical Oncologist, Max Mohali. Dr. Manishi Bansal, Radiation Oncologist. Dr. Rajpal Singh, Narayana Hospital, Jammu. Can I all please have you all on the stage? I request the chairperson to please introduce our speaker, Dr. Tejas Chandra.
Good morning, everyone. It is my privilege to invite Dr. Tejas Chiranjeevi to deliver his talk on recent advances in surgery of CA prostate. He has done his MCH in urology in 2016, followed by a 1-year fellowship in uro-oncology and robotics at HCG. He has a 5-year experience in robotics and uro-oncology. I would invite Dr. Chiranjeevi.
Thank you, Chairpersons. At the outset, I would like to thank DMCH Cancer Institute and Dr. Brar who invited me for this second conclave on cancer surgeries and the advancements. So we have looked at the diagnosis as well as the staging. Now let us look at what are the recent advances we have in the surgical part of the prostate cancers. So we know that the prostate cancer surgeries has been being done since the past 100 years. So if you look at the evolution of the treatment for prostate cancer, the first radical prostate cancer was way back described in 19th century. So in 1904, Hugh Hampton Young and Hasted gave the description of a perineal prostatectomy. Millen in 1945 opened the way to do a retropubic prostatectomy. Memela in 1949, he structured to do the way to do retrograde prostatectomy. And in 1959, the Campbell designed the antegrade prostatectomy. Whereas in 1966, it was the Charles Higgins who won a Nobel Prize for treatment of hormone-dependent prostate cancer, and that gave us a bilateral orchidectomy, which was a favorite for many of the surgeons as well as the urologists who would treat CA prostate across all the stages. So it was the landmark paper in 1983 by Walsh who gave the description of retrograde prostatectomy with the preservation of sexual function, and this was widely accepted in US, and most of the urologists and uro-oncologists started practicing the open radical prostatectomy. Then came the era of laparoscopic radical prostatectomy. In 1991, it was the Schussler who described the first radical prostatectomy. Though it was a very time-consuming and difficult vesico-urethral anastomosis, it was not very well taken up in US. But however, in Europe, many people started doing laparoscopic radical prostatectomy, and they gave techniques called as a heel-bond techniques and Monsouri's technique. Then came in 2000, the era of robotic prostatectomy started with the first radical prostatectomy done in 2000 in the Ford Institute. So then the generations of the robos came, SI, then XI, X, and the now present generation robo is an SP robo, which is the Da Vinci, and there are other robos in the market as well. So there were many approaches to the radical prostatectomy by using a robo. It was either an extraperitoneal approach, a transperitoneal approach, a rigid sparing site, even a perineal approach has been tried. So coming to the recent advances as such in the robotic system, it was the SP robotic system which was recently an FDA approved, because it's a single, it requires a single port. A surgery can be done with a small incision of 2.5 centimeters. It did address the triangulation and minimal clashes which was seen in less surgeries, and it can also be safely done as an extraperitoneal approach. And there are a few papers which says that you can do as a using an SP robotics. So current evidence now for single port robotics is only for localized prostate cancers, and Jihad Kok and his group has also used this for a perineal approach as well. So if you look at this is the SP Robo, which has a fiber optic camera and also the angulated the arms, which can help in minimizing the clashes and also can be used as a triangulations. This was a paper, interesting paper, which was published by Jihad Kok and group, where they used it as an outpatient basis treatment. So in this paper, this group did about 60 patients with clinically localized prostate cancer with no prior operative therapies. The pain at the discharge, the scale of pain was 0 to 1 in 37% of the patients. 88% of the patients were discharged on the same day of the surgery, whereas 96 were discharged within 24 hours of surgery, which means that the patients who were admitted a day before in the evening, they were discharged in the next prior day, but within 24 hours. So coming to the recent advances in the techniques. So the landmark paper which the Wall shed on the neurovascular bundle sparing, the same was utilized in robotic as well. So they then came the techniques called as interfascial, intrafascial and extrafascial. So, and there was also a larger series by Vipul Patel which says that landmark artery based neurovascular bundle preserving. So I'll be rather going on to the interfacial and intrafacial which we currently are practicing now. So this was a paper review article which said that if you have an intrafascial nerve sparing, it is a good quality of a nerve sparing, but it comes with a very low safety margin of a positive surgical margins. So you have to choose the cases accordingly and very carefully. So there was another interesting study which happened by Nikhil Vasudev and group, and this is the first Indian experience in our setup and HCG where we have done 5 cases of neurosafe surgeries. The neurosafe basically means that you remove the prostate very close to the neurovascular bundle, thereby having a neurosafe margin by a frozen section analysis. So in our demography, all the patients were 60 to less than 60 years of old with a clinical ISUP grade of less than 3, and all had a safe neurovascular margin along with the negative frozen surgical margins as well. So most of the patients, these 5 patients who had, they were sexually potent and were able to have intercourse at 12 weeks post surgery. These are the demographics. So if you look at the frozen section margins were negative, and also the final histopathological margins were also negative in this. So how do we do it? It's a brief description. So the prostate is removed. The paint which is done red is the right side, the blue is the left side. So you take a margin from the prostate, about 4 millimeter margin, and then cryoprecipitate and then take sections to know whether there is a safe margin or whether there is any positive surgical margin as well. So this was looking at the potency. So most of the surgeries they always looked at the trifecta. One was the potency, then was the continence, and then was the surgical margins. So this was one of the interesting papers which was done by Ash Tiwari and group, which says that anatomical restoration technique has a better continence among the patients with the localized prostate cancers, which mainly on the intermediate, favorable intermediate, unfavorable intermediate group and the low risk groups. So what does anatomical restoration means? It's the strategies is very clear and simple. It is only to leave intact the puboprostatic ligaments, the muscularis, the muscular collar, and the arcus tendon supporting the continence mechanisms. In these 50 consecutive patients where they did this anatomical restoration, the 95% were continent at 16 weeks. So this is the description which they said. So basically you leave all the areas onto the lateral aspect, do a vesicourethral anastomosis, and then suture the bladder to the fascia. So the same group also gave about something called as a hood technique. So the hood technique is nothing but going slightly cranial to that of the anatomical restoration, so that you preserve the detrusor apron, you preserve the puboprostatic ligament complex, then the arcus tendinous as well as the endopelvic fascia and the pouch of Douglas. So the one interesting part from this paper was the positive surgical margin was only 66%. When compared to the Ridges Paris of Bouchardy, it was almost 21 to 22%. And the continence rate were almost equivalent to that of the Ridges pairing of almost nearing to 91% at 3 months. So basically he says in the anatomical restoration was only this part, whereas over this part, Whereas in the hood technique, he goes all along the detrusor aspect, and also, if you can see, it forms like a canal or a cavity kind of thing, which gives an adequate preservation for the continence mechanisms. So these were the important advancements what I looked into, and I would like to show another. It's not नहीं जा रहा है. So this is small. We'll run a small video on a robotic radical prostatectomy. So you can use an SI or X or XI based. So if you have an X or XI, you can have a both as a for side docking or from the docking from the leg end. So the marking is always 18 centimeter from the pubic symphysis as the first as a camera port, and laterally you can fan out from 8 to 9 centimeter. You can have the fourth arm either on the left side or the right side, depending upon the assistant you have. If an assistant is a right-handed person, you can have the fourth arm on the left side so that the assistant has on the right side. So the first step is always look at the reflection of the peritoneum along with the pouch of the Douglas and take an incision along that. It basically it's about 1.5 centimeter, 1.5 inch from the reflection of the peritoneum. So the first thing you notice is the vas difference and the seminal vesicles. So now this is the dissection of the right seminal vesicle along with that of right vas along with that of the seminal vesicle. If you're doing a good nerve sparing, so at the base of the seminal vesicles, you don't have to use too much of cautery. Now you create the paravesical spaces. So by doing this, you're partly also dissecting for a lymph node dissection as well. So once the lateral vesicles are taken care, areas are taken care of, the next thing would be easy. Next easy thing would be to do is come from the front and drop the whole of the bladder along with the median umbilical ligaments and the medial umbilical ligaments. Try to always cut at the honeycomb appearance because that is the area where there is no much of a blood supply. The fourth one is opening of endopelvic fascia. Here we can see we are going intrafascial. We are taking, cutting the prostatic capsule a little more and then taking care not to injure the neurovascular bundles. So there are n number of ways of deciding where the bladder neck is. One is the puboprostatic ligaments, which forms the pubovesical ligaments, or else what you can do is increase the size of the balloon and ask the assistant to give a tug so that you know where the bladder neck starts. It becomes difficult in patients who have undergone a TRP. Otherwise, it's very easy to make out the bladder neck. And also sometimes it becomes difficult if there is a very large median lobe. So basically the hood technique, what you, as Tiwari says, that you leave all the part from that as a detrusor apron and go close to the prostate. So that has more of continence mechanism in compared to the other thing. I think to do all those, you need to have a low risk disease or a favorable intermediate risk prostate cancers. Per se, it was not a complete neurovascular bundle sparing, it was partial neurovascular bundle sparing. So there are two ways of taking care of the DVC. Either you tie the DVC and cut it, or you cut and suture the DVC. The only thing by doing cutting and suturing the DVC, you can gain that extra length of the urethra, which may not be possible with suturing and then cutting it. So we use 3-0 V-lock for all DVC sutures. So then the next, so if you can see, by after cutting and suturing, you will precisely know the length of the urethra, which can be adequately dissected, and quite a sufficient amount of urethra is there in the abdominal part. So the lymph node can be done either before the anastomosis or after the anastomosis, depending upon your convenience. So the ninth step would be a Rocco stitch. The Rocco stitch brings the plate out for the anastomosis closer by. So for the Rocco stitch, we take about 3-0 Stratafix tied in between, so that you have two needles to run on either side of it. You can start from 6 o'clock position or whichever position you like to. So your vesicourethral anastomosis is done always with a 4-0 V-lock. So again, this can be done either by 6 o'clock position starting, or from 3-9 posterior and then anterior. If you have a large median lobe and a large bladder neck, the bladder neck can be reduced by either a fish mouth or tennis racket, depending upon what kind of a bladder neck you want. Some people do it as a single layer, some people still do it as a two-layered. So the Rocco stitch which has been taken can also be run anteriorly as a second layer of stitch, but I don't think so that is going to affect in any way the continence mechanisms. Thank you.
Thank you, Dr. Tejas, for excellent presentation. and a very nice demonstrative video. The house is open for questions, please.
So we are stuck to only one technique, sir. So that is posterior approach, transplant and posterior approach.
Just for the audience, the registering is a posterior one in the first and then he has gone and the early that improves mobilization of the entire bladder. But in registering, you just go behind the bladder between the rectum.
Yes, you don't have to take down the DVC as in registering. So, but the only thing is you have to be very choosy for the cases for registering. That's what I believe, sir.
No, registering cases will be the same cases which will take up for nurse spelling.
Yes. But again, the catch is, yes, sir. But again, the catch is if there are any anterior tumors, then registering becomes very difficult.
Yes, the policies in registering are going to be if there is going to be a T3A.
Yes.
Then registering becomes much more margin considered.
Yes.
Very nice.
Thank you, sir.
If there are no more questions, thank you very much. Thank you, Dr. Chiranjeevi. Thank you.
Thank you all. I would request the chairpersons to please felicitate our speaker. I request Dr. G.S. Brar sir to please come and felicitate our chairpersons. Can we also have Dr. Deepak Abrol on the stage for felicitating our chairpersons, please? We have Dr. Jaspal Singh as the chairperson. Dr. Manjeet Jora. Dr. Sunandan Sharma. Dr. Manishi Bansal. Dr. Rajpal Singh. Thank you all. Continuing our discussion on treatment options for prostate cancer, our third discussion is advances in radiation therapy for early stage prostate cancer, for which we have as chairperson Dr. Tejinder Kataria, who would be joining us virtually. We're trying to get connected with her. We have Dr. Jaineet, Senior Consultant Radiation Oncologist, CMC Ludhiana, Dr. Shikha Chawla, Radiation Oncologist, Patel Hospital, Dr. Nidhi Gupta, Radiation Oncologist, GMC 32 Chandigarh, Dr. Jagmohan, Radiation Oncologist, AOI Jammu, Dr. Sandeep Kukkar, Medical Oncologist from Suhana Hospital. May I please request you to come on stage? request our chairperson to introduce our speaker, Dr. Banerjee.
Good morning, everyone. We move on to the next session. I now invite the next speaker, Dr. Suzovan Banerjee, who is an associate radiation oncologist, associate director radiation oncologist working at Medanta Hospital, and he's going to talk on advances in radiation therapy for early stage prostate cancer. Dr. Banerjee, please.
Thank you, Honorable Chairperson. Thank you, organizers, for this opportunity. So we will be discussing advances in radiation therapy for early stage prostate cancer. So it can be actually a very big topic. It is difficult to consider everything in 15 minutes, but we will try our level best. So early stage prostate cancer is basically T1, T2 cancer, which is within the organ confinement, and it has no nodal space, no distal metastasis. So generally low risk and intermediate risk prostate cancers are classically considered early stage prostate cancer because of the risk factor, but then high risk cancer which has not actually spread to nodes or doesn't have a distal metastasis and is confined with the prostate can also be considered an early stage prostate cancer. So the advances in management of prostate cancer in radiation, it can actually start from decision making on radiation oncology, radiation therapy dose and treatment techniques. We can see different conventional hypofractionation, SBRT, brachytherapy, newer modalities of photon treatment like MRI guided external photon treatment. There may be newer modalities of radiotherapy like proton therapy or carbon ion therapies and recent clinical results. So we will have been interposed all of them in the following few slides. So localized prostate cancer, we all know the definitive treatments. It can be definitive radiotherapy, it can be with or without androgen deprivation therapy, it can be hypofractionated, ultra hypofractionated, it can be brachytherapy, high dose or low dose rate, it can be EBRT, plus brachytherapy as boost, it can be radical prostatectomy as we saw in the last session, and it can also be watchful waiting or active surveillance depending on the patient prognosis. So what are just a single slide on landmarks of prostate cancer radiotherapy. So in the first treatment of prostate cancer by radiotherapy was actually not teletherapy, it was brachytherapy, and they used to use radioactive radium seeds in gold capsules or in glass capsules. They had many pros and cons, and finally because of many toxicities and many things, this went out of favor after advent of this external beam radiotherapy. The initial external beam radiotherapy was kilovoltage only, so it was inadequate to give adequate dose to the prostate that is actually deeply situated and surrounded by very critical organs. So with the advent of megavoltage radiotherapy, encouraging started pouring. So if we see the timeline of radiotherapy in treatment of prostate cancer in the post-radium era, we can see from 1950 to 60 actually the megavoltage, then advent of TRUS for brachytherapy purpose, then LDR seeds came, retrobeam placement of radium seeds, brachytherapy and teletherapy techniques went hand in hand till this time in year 2000 and somewhere around we got hypofractionation, advent of knowing about the factors of LQ. From the LQ model, the alpha and beta ratio of prostate cancer, that was very special, that came into the hypofractionation, SBRT, and now it has gone beyond 2010 to proton therapy, MRI-guided brachytherapy. So the list is actually continuing. So treatment options of prostate cancer, here you can see in the table all possible treatment options are given stage-wise, and it can be local, intermediate and high-risk patients. So the treatment options can be monotherapy, both radiotherapy, conventional hypofractionation, or it can be a combination of monotherapy and boost, maybe in the form of SBRT or brachytherapy. The green tables actually are the conventional or proven treatment or can be considered the standard of care. You can see here hypofractionation treatment is already considered as standard of care. And at the same time, SBRT is there, which is a little bit in the grey zone, but more and more evidence are pouring in, as you can see down. And then there are other treatment options which are actually in black that should not be allowed for these treatment stages. So first, dose escalation studies, a single slide. We already know that with the advent of dose escalation in prostate radiotherapy, the cure rate has increased actually, biochemical failure-free survival, and a number of studies are there. In number of studies we have already put here the randomized trials actually, and it was seen that with more than 74 gray in intermediate and intermediate risk, at least more than 74 to 80 gray, 78 gray should be given, and for high risk cases something around 80 gray should be sufficient to control the biochemical disease control, and it happened because of improvement in radiation delivery techniques like IMRT and IGRT. And although most of the trials has not been able to prove it clearly, but evidences are there that shows that with dose escalation there is also an improvement in overall survival. So then what actually, why do we need to change this thing when the treatment results are actually at par with the surgical treatments with conventional fractionation? Because there are actually burdens on patient and the healthcare. IGRT is the standard. Now most of the centers in India and this part of the world are actually IGRT centers. How much we say that India is a poor country and we have no resources, but we have a lot of centers and most of them are doing IGRT. And image verification is the essential part of IGRT, and most of the busy department, the most frequent call we receive as technologist is iski bowel mein to gas dikh rahi hai, aake ek baar dekh ke jaiye. So that's how it is. So it's a burden on us. At the same time, it's a burden on the patient also, that 7.5 weeks of treatment, daily bladder and bowel care, toxicities, may be cumbersome at the end of the treatment, logistics, jobs, staying outside. At the same time, SBRT or hyperfractionation take less time, and the patient can go to office very quickly. So rationally for hyperfractionation in CA prostate is actually this alpha and beta, that is the magic thing. So we now know that alpha by beta is less, around 1.5 to 2. And so the large dose will be more damaging to the prostate compared to the tissues outside who has a bigger alpha beta, actually 3 or around. So it will be sparing the normal organ, and so it is more sensitive to size of the fraction. So here is the radiological advantage that is shown in a graph. You can see on the left hand side with the lower alpha by beta that it actually effectively produces more BED compared to a more alpha by beta of 10 around for acute responding tissues or head neck cancer, where the hyperfractionation actually doesn't yields a bigger BED. So in prostate cancer, a higher alpha by beta should be exploited for that reason. So there are again in hyperfractionation, moderate hyperfractionation, as we talked about, less than 5 Gray, around 3.5 to 4 Gray. There are innumerable studies and trials, but for us to understand over the timeline, a lot of trials, a randomized trial has also been conducted, and some of them has some lower BED doses, but most of the trials has proven that the results are not inferior, and the toxicity is also similar. There is definitely hyperfractionation trials are not inferior, if not superior, to conventional fractionation, and the results and toxicities are all comparable at least. So conclusion from those trials are that most of the trials are now more than 7.5 years old and sufficient to predict that chronic toxicities are same as hyperfractionation. And but some people say there are immature results, but in this field, especially new and near literature is coming up every day. So moderate hyperfractionation is safe, as you can conclude, reduces the treatment time and take care of logistics, and is obviously non-inferior to efficacy, if not superior, because of higher BED it can deliver. So after moderate hyperfractionation, we can see a little bit of extreme hyperfractionation, that is we divide it as SBRT. So for that, ideally HDR brachytherapy is the ideal, because that is actually the gold standard on which all hyperfractionation trials has been designed. So but it has needs some mature experience, not done in all centers, it is invasive. But the main issue in India is actually less of experience and infrastructure, not about this invasive hospitalization and anesthesia, because surgeries do happen, these are all invasive and we are doing that. So SBRT is the non-surgical alternative to brachytherapy, and because there is a huge experience in SBRT and it is coming up, we have to see that also. So it has 3D imaging or localization is masked, strict immobilization, highly focused beams, the machine should be good, and IGRT is masked to improve the precision and accuracy. So now we can see the slide. In USA actually there is a study that shows there has been a rapid increase in SBRT, as you can see, compared to decline in high dose HDR brachytherapy, especially as a monotherapy, not in a boost setting, especially in the monotherapy setting. So SBRT is actually picking up very fast. So there are again for SBRT trials we can find many studies, so it is not possible to compile everything. The best thing is to go some to review article, and you can see the table here. Stereotactic radiotherapy for prostate cancer, it is feasible. The toxicities are again comparable with conventional and hyperfractionation treatment schedules, and it is very convenient for the patient. There are actually few randomized trials on SBRT with hyperfractionation and conventional treatment, and even they have even used in some trials they have used 3D techniques, older techniques. But even with these older techniques, these SBRT results are equally good. No difference in overall survival or biochemical survival, actually may be little better. and most of the in patients with high volume of prostate, urinary side effects can happen little more, and most of the trials include actually low risk and intermediate risk patients. So high risk patients has been included, but it has always been less, in the range only 10 to 20% of patient population in most of the trials. So stereotactic body radiotherapy for prostate cancer, SBRT can also be offered as a boost to shorten the overall treatment time and to give advantage of HDR, to give the advantage of more PED. So those are also studies are there. So stereotactic body radiotherapy, there has been a meta-analysis which shows that estimated grade 2, grade 3 toxicities may be little high in SBRT cases. Increased dose is associated with improved biochemical control, and little bit of generative toxicity may be little higher. But at the end of 5 years, the late toxicity actually catches up in hypofractionation on SBRT, and they become equal. So there seems to be a limit, because we cannot increase the BD indefinitely. So in both hypofractionation and SBRT, we generally try to limit the dose. Higher, the accepted limits should be safe, deliverable, while maintaining the tolerance of the rectum and bladder. Advantage of high dose SBRT can be, it gives more pathological response. It has been proved in multiple studies, post biopsy, post treatment, the biopsy has shown. Then better PSA kinetics can be there, the fall in PSA is better, the biochemical control is more rigid. Then equivalent toxicity, if it is done in proper hand, in a proper institution, in a proper way, time and logistics can be of great help to the patient. So the recent evidences indicates that there are numerous studies showing similar biochemical control with no difference in overall survival, providing hypofractionation radiotherapy as a safe treatment. Moderate hypofractionation can be considered as a standard of care now, but obviously with the IGRT facility and extreme hypofractionation as SBRT we have discussed, so BED more than 180 degree is probably not required. It gives a plateau and may be associated with more toxicity. And prostate volume is bigger. When it is bigger, it may actually increase more toxicity, and at the same time the IPSS score and the urinary frequency score of the patient should also be documented. So in our Vedanta hospital, we do practice SBRT very routinely. So we can see one patient done with SBRT by Simon knife, fiducial gold sheet, and you can see how beautifully the urethra has been spared. And in our department, one of our colleagues we documented the urethral contouring techniques. We have our own experience of hypofractionation documented in literature, and we generally practice both in radical and in boost setting for a high risk patient. And the dose is generally, radical setting is 42 gray in 7 fraction. So now, what is the important thing in hypofractionation or SBRT is that is sparing the rectum, because we all know gas can actually be in the rectum, it can come all of a sudden, and it can put the prostate rectum in the PTV, and the prostate can be displaced. So it is very important that we need to understand the movement of the prostate in a dynamic way, or we need to make it a stable position. So there are multiple ways to move the rectum away from the bladder, and it can be putting some hydrogel between the prostate and the bladder, which are also available in India now. It can be a calypso system, it can be rectal balloon that is used often, or it can be putting gold fiducials in cyber knife or in IGRT facilities by LINAC also, that we can practice to make this image verification more robust and spare the rectum. So placement of hydrogel special is actually more popular considered to other techniques, and there has been a clear difference in percentage of rectum receiving 50%, 70% and 90% dose with use of hydrogel spacer OR, and it has actually been translated into clinical benefit of laser toxicity when hydrogel spacers are used in prostate SBRT. So now, I am personally a fan of brachytherapy, and you have seen what SBRT is called a virtual brachytherapy. So we have seen a lot of virtual thing, even virtual marriage during the time of pandemics. But then virtual is virtual actually, and real life is real life. So whatever SBRT is called a virtual brachytherapy, although we have enough evidences, but it has no head-to-head competition with the SDR brachytherapy, not yet done. So evolution of brachytherapy with time. So retropubic seed placement was the first time it was done in 1996, 1960. And then over the time TRUS came, TRUS guided placement of seeds was done, CD guided planning was done, and over the time then again we had this MRI guided brachytherapy, USG guided brachytherapy, and nowadays even brachytherapy is done with the use of robots. So there has been a phenomenal improvement in technology of brachytherapy. So brachytherapy actually gives the best dose distribution. You can see even it gives a better distribution than the proton therapy. So brachytherapy gives uncomparable dose to any other external beam form of radiotherapy. So it is undoubtedly the best form of treatment in expert hands. So brachytherapy as a radical treatment, it can also be used as a boost for a high-risk patient. Very recently, it has been shown that brachytherapy actually should be used for all high-risk prostate cancer patient as a boost who doesn't have a nodal metastasis. There is a level 1A evidence for that, and that is the one reason actually use of boost brachytherapy in US and Canada is actually on rise. It has been documented. So this is the standard of care for brachytherapy in a good center. It is guided by trust. The truss remains during the course of placement of the catheter and during the course of treatment. Whole time the patient lies in the lateral beam position for the insertion of the catheter to planning and dose delivery. So there is zero immobilization of the patient, and the planning is done while the patient is still in the OT table. And this treatment technique is very much common in Europe or Canada. In our part of the world, because of low practice of brachytherapy, low volume, those are not actually available. But this is the standard of care. And in our hospital, Vedanta Medicity, we do SDR brachytherapy with our own template, and we have done quite few cases, but we do generally it as a boost only. So then new things, little more things that focal boost in intraposterior tumor. There is a new concept, and it actually improves the biochemical free survival and disease free survival according to a few studies that are available. So another thing is MR guided hyperfractionated radiotherapy. Currently emerging data promises that it's a novel technology and very promising in terms of tolerability. It actually gives a very good outline of the OARs, and dosimetry results are available, but mature clinical results are still not available to compare, but hopefully it will give very good results compared to our better results actually in terms of toxicity. But then there are some problems also in MR guided brachytherapy because it takes longer time for SBRT in MR brachytherapy. The bowel movements and this bladder filling can be erratic. It can actually make the patient less compliant of, and the residual volume changes during the plan needs to be repeatedly changed. At the same time, MR guided brachytherapy MR guided external beam radiotherapy will probably be better in sparing the neurovascular plexus. Mature results are yet to come, but we are waiting for those things. So proton and carbon ion, those are big things now because India has also got a proton center and many more are coming. So about a study of 54,000 patients is already available from throughout the world. It is very much feasible, safety. The results are there which shows the better overall survival and better biochemical control, but the results are highly not mature, and it will take some time here to understand this. So single fraction radiotherapy, this is a new thing that has come up again. So in external beam radiotherapy there are two trials, one is the POSENT and the SHORT trial, and both have used single shot radiotherapy, but that is still not the standard of care. More things are coming. SDR brachytherapy is matching the technological goals, and you can see that SDR brachytherapy is innovative, and you can do it in MRI, you can do focal boost, you can do rectal spacer, everything. Brachytherapy, but single fraction SDR brachytherapy is not the standard of care. So here in this slide, you can summarize what are the modern treatment. You can see this can be proton, it can be fractionated proton, it can be fractionated photon, it can be an SBRT or hyperfractionation treatment, or it can be an SDR brachytherapy or a seed brachytherapy. Seed brachytherapy we do not discuss because that is not widely practiced in India, and those are those profiles. So, but we are at the crossroads, genomics and many things are going there, especially in prostate cancer, one of the most explored sites because of the Gleason score, risk assessment, nomograms. In coming years, many things will decide the prostate radiotherapy things, especially MRI imaging. The volume of the MRI, how it looks in the tumor, what is the genomics of the tumor, those are going to guide us to dose, amount, technique and follow-up also. And long-term toxicities already has been proved to be shown to be affected by genetics of the patient in prostate especially. AI is the future on brachytherapy, future of prostate radiation therapy, and a lot from decision making to follow-up. AI will guide us soon, especially in prostate cancer, because most of the work is in prostate cancer only. Actually, 3 years or 4 years back, I wrote a story on this future of prostate brachytherapy, and it was published in AORI newsletter. It was about a person who was diagnosed with prostate cancer with biopsy, and how a patient, a robotic doctor, is a science fiction, but it was published in AORI. So that is how where we are, and thanks for the patient hearing. And I acknowledge all my whole team there, our chairperson Dr. Tejinder Kataria, Dr. Shyam Singh Bist, whom I have borrowed a few many slides, and my other colleagues. Thank you.
Thank you for a very comprehensive talk. The topic is now open for discussion.
What about
So complications are associated with all types of treatment. So it will be associated with radiotherapy also. So then there are complications, maybe urinary frequencies, urinary stricture in SDR prostate or SBRT. But then over all studies, it has been consistently proved that those results are actually conventional hyperfractionation, SBRT and surgery. The results are almost similar with a little up and down in some domains, maybe. So that's the
Dr. Susovan, thanks. That was a wonderful talk. So, as a radiation oncologist, you know, brachytherapy facilities require a big setup and it's not available everywhere. You said virtual and brachy, you cannot compare. Virtual is virtual, but everywhere we don't have that facility.
Madam, actually, the recent JKIS2 guideline of brachytherapy says the only essential thing the department should have for prostate brachytherapy is actually a truss machine. So that is the minimum thing. While all our centers are getting PET scan nowadays, you are seeing when we were doing MD, PET scan was hardly available in eastern part of the India. Now it is present in all tier 2, tier 3 cities, and then we cannot afford a truss. So, and the needles are actually available in India also. There is one company, Kalyani Private Limited, they sell the needles for a very cheap price, 1,000 per catheter. Then the template is actually the elector people give template to all people. We must be having in our department because it lies under the but nobody knows what is there in the department because nobody is interested to know if you can do so. It is about the mind block of our setting to not to do a prostate brachytherapy. Prostate brachytherapy as such is easier than gynecological brachytherapies because prostate is an organ that is confined in a capsule, is very predictable. It has actually, if you see madam, because the newer things that AI and radiomics, genomics, the main things that are coming in prostate treatment, prostate is so much predictable organ about its biology, its treatment, its response and its outcomes and its follow-up even. So no other cancer is so much predictable as prostate. And then it is within the capsule that we have to place the catheters only. Just observation in the center. It will be very easy.
And another question that you have SBRT plus brachy both in your setups. What is your experience and what would you go
Madam,
into?
as a center, we have more mature SBRT experience than brachytherapy. That is for sure because SBRT, we have a dedicated SBRT machine, Cyber knife, and then we have also electric SBRT setup of all things. So we do both LINAC and Cybernet based SBRT. So we are fortunate to have both the systems and we definitely have more experience in SBRT, not brachytherapy, HDR brachytherapy. HDR brachytherapy we are picking up slowly, we are also learning. It is not that we are expert in HDR brachytherapy, but then few cases we have done, we understood that it is not a rocket science to do. And if somebody can do interstitial gynec brachytherapy, it is more easier to do it because it's in the perineum. The only difference maybe it's the male and the female. Otherwise, a newcomer will actually think it is doing the same thing maybe at times.
Thank you.
No, madam, we do it as a boost therapy. We after giving 50 gray EBRT to the prostate and 45 or 50.4 to the nodes, we actually give 12 to 15 gray of HDR single fraction to the prostate. Depending on 12 to 15 gray is good enough. It is advised to give 15 gray, but we tailor the dose because we are also beginning. We are not doing every day, so we generally are moving with caution.
So nice presentation, Sushil. That my question also ki when you are giving CK boost or brachy boost, so what is the total dose to the prostate? So and if you are doing dose escalation, have you seen any increase in late toxicities?
No, late toxicities we have not seen increase because SBRT we mostly do with Cyber knife, so that is another advantage for us. And with the gold fiduciary placed, it actually is a real-time tracking. So the toxicities are very much comparable.
So total dose is around 80?
Total dose is 80. It will go if you use SBRT and you will SBRT, it is around 80 to 88 to 90 it comes, but in brachytherapy it can go up to 100. What we give in brachy single fraction, it increases if it goes up to 100 BD.
Sir, you talked about the gels what is your experience with respect to the gels?
We do not use hydrogel special, although I have seen it as an observer in some institution. The use of hydrogel is very important, mostly in when you are trying to do a single or two fraction SBRT, then it has more role to play. Not in normal hyperfractionation or SBRT. The imaging facilities available with us in all centers nowadays, maybe LINAP or CyberKnife. A good imaging and a good meticulous imaging is good enough to avoid any rectal toxicity. But yes, when you are doing a single shot SBRT or a brachytherapy, or you are doing a re-radiation, or your tumor is very close in the posterior part of the prostate, then you may consider using hydrogel. But there are centers in India who are already using them. But it's very essential for a re-radiation setting.
The prior protocol with respect to the use of gels remains the same, like we are using the bladder protocol.
Yes, we are not using it, as I told you. We are not using it. It should be used for irradiation purpose only in my city, because it is very costly and not available.
And it has to be used after every fractionation. Prior to every fractionation, we'll be using it like.
No, in brachytherapy, if you give it overnight, it will work. It will not go in that way. There is a lot has been documented actually, and all studies points to same result wherever you go on roads to roam actually all treatment facilities of prostate. So urethral toxicity in prostate brachytherapy in expert hand is less than SBRT, but at the same time, if it is non-expert hand, it can be catastrophic because it can directly penetrate the urethra, because urethra is the main thing we need to spare. So, but in expert hand, it will be minimal. We have done not a lot of cases, but I told you. But for us, whatever we achieved the dose, it was less than 120% of the total dose. Yes, that is what is 125 is the maximum dose the urethra should receive according to JKS2 guidelines. So we could have managed to 105, 110% of the dose you prescribed to urethra. No. Till now we have not seen. But long-term toxicities are yet to come.
If there are no other questions, we close the session. Thank you very much for a very interactive session.
Thank you all. I request the chairperson to please felicitate our speaker. Request Dr. Sandhya Sood ma'am and Dr. Sumit Jain to please come and felicitate our chairpersons. Dr. Nitish, can you please join us on stage?
I would like to thank our respected chairpersons, and I wish we could have joined Dr. Tejinder Kataria. She was supposed to be joining as virtual chairperson, but because of the delay in the sessions, she had to go somewhere and we missed her as a chairperson. Thank you so much.
Dr. Jenny. Dr. Shikha Chawla. Dr. Nidhi Gupta. Dr. Jagmohan. And Dr. Sandeep Gupta. Due to the shortage of time, we won't be breaking for tea. In case anybody is interested, we have the tea counter outside. They can grab a cup of tea or coffee from there, please. And we'll be moving on to a very interesting part of our conclave. We have a debate between a surgeon and a radiotherapist deciding what to choose on a prostate cancer patients. For which I request our chairperson, Dr. Satish Jain, our Senior Most Surgical Oncologist, Mediways Hospital, Dr. Avdesh Pandey, Senior Radiation Oncologist, GMC Chandigarh, Dr. Amit Dhiman, Medical Oncologist, Deep Hospital, Dr. Sanjeev Bansal, Surgical Oncologist, Bathinda, Dr. Archana Datta, Radiation Oncologist, please. I request the chairpersons to introduce our speakers, please.
Good morning, ladies and gentlemen. You have listened to very interesting and very great advancement in the field of surgery as well as radiotherapy. So now we are going to have a debate. What to practice in early prostate cancer, whether surgery or radiotherapy. I know radiotherapy, very few centers are doing that job which Vedanta is doing for early prostate cancer. But for surgery, robotic surgery, there are many centers in India. So people have started robotic surgery quite a bit in prostate cancer, and it's quite safe, and there are advances in the technique also. So for that debate, I'll call first Dr. Sopan Sood, leading urologist from Jalandhar, uro-oncologist, as a senior, he's working as senior urologist at Patel Hospital, Jalandhar. I know him well, and he has been doing a lot of good job, laparoscopic surgery, urology, as well as robotic surgery. So Dr. Sopan Sood, you will talk about favor of points for surgery in early prostate cancer. We'll have a debate at the end also, both sides.
I just learned from Dr. Banerjee that the first radiotherapy was conducted for prostate cancer was conducted back in 1909. I didn't know that. And I quickly then went to the net and found out when the first radical prostatectomy was done. And it turns out it was done by Hugh Hampton Young way back in 1904. So the treatment of prostate cancer remains the same. It's more than a century. It is either radiotherapy or it is surgery. I think the context is that the technology has changed. It is not really the treatment which has changed, but the technology has changed, and therefore the title of my topic is the rise of the machines. This is radiotherapy versus radical prostatectomy in early prostate cancer. So we know, and already Dr. Banerjee told us in quite detail how far radiotherapy has come in the last century. I would also like to put my hand in there and tell that surgery has also advanced a long way since it started off in 1909. It's no longer the child of somebody trying to learn tennis, and you can see winner of 21 Grand Slam titles trying to earn another one in this thing. Also, when Gurpreet gave me that topic, I had a little bone to pick with him. He actually did a little bit of a match fixing and said that I must speak on surgery in early prostate cancer. And thereby he tried to fix the match and saying that only radiotherapy, or at least radiotherapy, should be a contender in the thing. That's like presenting statistics, something like what Rajdeep presents and says that the maximum number of journalists are killed in India, but actually India has the lowest per capita number of journalists killed in the world. So starting there, I hope you can see the images. This is a 5-year-old NCCN guideline, the debate was the same then, EBRT versus radiotherapy, and the debate is the same now, EBRT versus radiotherapy. I have gone through several such debates, and I have learned from my peers also how to proceed in these debates. Now, the first thing is that we need to fix the boundaries of the debate. We need to find out where we are going to be playing. Otherwise, CA prostate has a total confusing literature pattern over the last 2 or 3 decades. First of all, there is no point in doing 5-year survivals, 5-year disease-free rates, 5-year overall survival. All patients will survive, whether you treat them or not, they will be there after 5 years. They might be a little worse, they might be a little better, but they will be there. And you have to really factor in the various modalities and various things which have been done to the patient, and to separate out the 2 modalities and then find out which one is better. Well, better to fix the goalpost before you start playing the game. So we can fix a few protocols: overall survival, cancer-specific survival, progression, biochemical or actual progression of the disease, whether any adjuvant therapies were used in either of the 2 modalities, and what happens to the 2 most common complications which are associated with the urinary tract, whether incontinence or erectile dysfunction. And of course, I tell all my patients that it is not a one-time treatment. It's not as if you come to the hospital today, 2 months later, you are treated and you never have to visit the doctor again. You need to keep visiting the doctor either for the cancer or its complications all the way through till your life ends. So we have to see, and you know there's going to be a 10-year survival, 15-year survival for early prostate cancer, and you have to manage the patient through this entire 15 years. It's not about that first 7.5 weeks, as Dr. Banerjee said, or about the 3 days of radical prostatectomy for which the patient needs to be stay admitted in the hospital. I know my co-debater will argue on the PROTECT trial, and she will also argue on the Caesar trial. Well, I'll give her whatever she wants to stipulate in those arguments. It is an excellent trial. PROTECT trial is an excellent trial. But I'll just point out a few fallacies, and I think because she's batting second, so she might be able to correct a few. It's mostly a decade-old study. It was mostly about 3D conformal radiation rather than IMRT. And it was not about robot-assisted radical prostatectomy. So they twisted the playing field by not considering robot-assisted radical prostatectomy in most of those cases. And all of the patients in this trial, they had actually received NADT. Even the active surveillance group had a low mortality, so there was no point in comparing the various groups of patients which we had to do. By the time the Caesar trial had come through, one of the authors themselves, they pointed out a problem that the reporting of incontinence and erectile dysfunction had gone up because there was a lot of media attention to the trial, and the people were self-reporting higher numbers as compared to what they would actually report. So that has actually poisoned the data and how the data has to be evaluated, and I'll leave it to Dr. Pandey to perhaps comment later on that. However, without going through too much of an argument, the overall survival, if there's a PROTECT which says that the overall survival was the same, there is a huge Asian study of Chinese study which is more contemporary or more related to our part of the world, about 17,000 patients which were evaluated, and the overall survival was mildly in favor of radical prostatectomy. As you can see, let me get the. So even the 2-year survival, 5-year survival, 10-year survival, in all cases there was slightly more in the radical prostatectomy group. I am not saying that this was clinically significant. I am saying that it was there in those studies, which was not documented in the PROTECT and the more visible studies which were there in the literature. Similarly, if you look at the cancer-specific survival, again, in the cancer-specific survival also, the survival was more in the radical prostatectomy group in the same study. It was a meta-analysis, 340 studies. Down shortlisted to about 12 studies, and then out of that 17,137 patients considered, and then the overall survival and cancer-specific survival both were higher in the radical prostatectomy. I think most of the radiotherapists will now start agreeing that at least in the high-risk group, the overall survival is better in the radical prostatectomy group rather than in the radiotherapy group, and there will be multiple studies which are showing the same, especially more contemporary studies in 21-22 as they are coming. We must remember that most of these studies are showing a 10-year, 12-year, 15-year follow-up, and therefore the machines which were under used today were not present or were not in the same category of modernization as the current machines. So another analysis was what was the time to biochemical failure, and if you look at the graphs, I think you can see the blue graphs are the radical prostatectomy one, the red ones are the radiotherapy groups, and you see the time to biomedical failure, and the incidence is less in the radical prostatectomy group as compared to the radiotherapy. At the end, yes, I'll agree with my debater that most of the other parameters were probably the same in the radiotherapy and the radical group. What about adjuvant therapy in the PROTECT and the CSER trial? I'm sure some of you will be able to entertain, but or will be able to know more. But most of these patients had received adjuvant ADT, adjuvant ADT post-operative, and the comparison was actually not fair. It was like asking Bhuvneshwar Kumar to pole spin with the left arm on the around the wicket, and therefore make sure that the batsman can throw him out of the park. And one of the main problems with androgen deprivation therapy remains the metabolic syndrome, osteoporosis, changes in body composition, sexual dysfunction, muscle strength is decreased, quality of life is poor, and cognition differences are there, and they do turn to crop up somewhere 2 or 3 years after the ADT has started. Was the ADT necessary in all the on all the patients who underwent radical radiotherapy? I can tell you from my experience of radical prostatectomy that at least 23% of the patients actually downstaged once the radical prostatectomy was performed and did not need an ADT. But there's no way the radiotherapy people can tell us that. They have to give ADT to all the people, because whatever they did, andar hi reh gaya. What happened in Vegas stayed in Vegas. Right? What happened to the associated conditions? So, for example, there are other morbidities which you must consider. I'll just point out 3. 7.5 weeks of therapy. 7.5 weeks of therapy going in PGI. Imagine staying in Chandigarh and for 8 weeks, the cost would go through the roof. The convenience would be really, really bad, versus 2 or 3 days stay for a radical prostatectomy, a visit after 15 days, and then a 3-monthly follow-up. What happened to the patients who had a bladder outlet obstruction? You know, the AUA screening standard, they say that a normal patient who does not come to the urology department doesn't need PSA screening. But a patient with lower urinary tract symptoms who comes to the urology department, he needs a PSA screening, whatever the age group, he needs a PSA screening. Otherwise, you have to do a discussion with the patient whether to do a PSA or not. These are the patients who actually underwent the PSA. They already had lower urinary tract symptoms, and then they presented to the urology department, they got a PSA, they got a biopsy, and then they were diagnosed to have prostate cancer. I can say with surety that there were very few patients who got screened on their own and then turned out to be having prostate cancer, although it does occur in communities. But these were the bulk of the patients who presented both in PROTECT and in the CSER trial. And what happened to these patients? What happened to the bladder outlet obstruction? Was it treated pre-operatively? Was it pre-radiotherapy or not? Well, let me tell you, the operative risk of TURP and robot-assisted radical prostatectomy is almost the same. So, अगर आप TURP करा के radiotherapy इनको करा रहे हैं, you are actually subjecting them to 2 therapies. You could have simply undergone a robot-assisted radical prostatectomy, and it would have sufficed the job. Lower abdominal hernias. I'm just taking out 2 conditions which are very common. I'm not taking the rest of the conditions, hemorrhoids, etc. Ulcerative colitis, this, that, and everything is there. A host of other conditions. We are not need to focus only on the prostate. You have to manage the patient for the next 15 years. So what happens? RT will complicate all management of all hernias in the lower abdomen, whether you do it before the radiotherapy or whether you do it after the radiotherapy. So here's the operative risk in some literature about the operative risk in radical therapy, radical prostatectomy, which is the same as PCNL or any other benign surgery which you might be undergoing. I also need to clarify to you the incontinence bit. Whenever a patient, I send my patient to the radiotherapy department, he comes back and he is well informed about the incontinence and the erectile dysfunction which he is going to get, which possibly I am not even going to discuss with him. So this is a study which shows you the incidence of, is this working? Okay, this is the pointer. So just incontinence, all the time incontinence happened in just 2 out of 256 patients. So that's approximately 1.2% or 1.3%, and most of these patients, they are diabetic and they are of the older age group and they have poor muscular structure. In fact, currently, when we are doing robot-assisted radical prostatectomy, we are not even counseling our patient about incontinence, because we know at the end of 2 weeks or 3 weeks, since we are doing a lot of radius-sparing radical prostatectomy, almost 50 to 60% patients will be continent at the removal of the catheter after 12 days. They will be continent. Why bother them about these sleepless nights that they will be leaking urine or having to have a diaper after the thing? Another 30 to 40%, 30 to 35% will gain continence within the first month. At least if you don't point it out to them, they will not come back and complain to you that they are leaking urine. That is one of the things regarding the incontinence which I would like to point out. Regarding erectile dysfunction, what happens to erectile dysfunction after treatment for prostatectomy? These are 2 most important batsmen in the radiotherapy group. Erectile dysfunction definitely is more in the radical prostatectomy group, but mostly in the earlier part. Later on, they will get the same kind of erectile function, or the Shim score will reach approximately at the end of about 2 years, it will reach the same as it was pre-operatively. But in radiotherapy, it is the other way around. They have better clinical sexual function in the beginning, and it deteriorates as time passes. And since most of these patients are already on ADT, the libido is already gone, so there is no assessment of the sexual recovery or sexual function in these patients. Also, I have found in the Indian subset, erectile dysfunction is not as important to the patients, especially when they are more than 65 years of age, and we are paying too much attention to it. Yes, definitely they are sexually active, and you need to ask them. But when you start tabulating the results, many of them are not really bothered whether they have any erectile function or not. Third aspect which more of the radiotherapists will concentrate is कि 10 साल की lifespan होगा तो ही हम लोग, then only we will suggest surgery. If it is not, a 10-year lifespan is not there, then no point to do surgery. Well, what is the expected lifespan of an 80-year-old? Let us say in US. In India, we don't have such good documented figures. The average life expectancy in the United States is 7 years for 80-year-old white man. Now, this is the average life expectancy. You increase it by 50% for the healthier quartile. So an 80-year-old healthy man who is in the top quartile will have another 3 to 3.5 years. So his life expectancy at 80 years is the same, is more than 10 years. Now it is 10.5. So my upper limit for doing a radical prostatectomy would be based on the expected lifespan of the 80-year-old man. If he is having a good physical health and all, I will offer him a radical prostatectomy because he is expected to stay alive for the next 10 years. The real pitch in which we would like to compare and we would like to bat against the radiotherapist is on the complications. It is the complications which will make the difference to these patients, because when he got the radiotherapy, he was 70 years old, but when he started having the complications, he was 80 years old. His tolerance has decreased from 70 to 80. If you ask a 50-year-old man that आपको injection लगना है, the response is different. But when they come, when they are 80-year-old or they are 78-year-old, then 75-year-old, and they come to the hospital, their first question is, will there be pain? Will there be pain? So they are very, very pain sensitive in the 8th and the 9th decade. They don't want any pain, and the quality of life is of utmost importance to these guys. So most of the complications in radical prostatectomy are going to occur in the first 2 or 3 months. That's all. So see the list of complications: any hernia, retention, rectal injuries, lymphocyte sepsis, everything is going to occur is related only to the surgery, and usually over in the first month. So it is over when the patient is healthy, and patient is intolerant, mentally prepared, he is under consent. When do the complications in radiotherapy occur? They will occur. They will be GI and geotoxicity will be there, and they will increase as the time passes. So if you do the acute toxicity bit, you will find that quality of life will worsen. So this is what Rajdeep is saying actually. The quality of life worsened the most severely in patients immediately after intensity modulated immunotherapy, but even at the end of 2 years, it was still 25%. So it did worsen in the initial phase but it did not improve to the point where it would have improved after radical prostatectomy. So what happened to the obstetric symptoms? They are still there, all of them, after even SBRT. Dr. Banerjee was telling us great things about SBRT. And what happened to the late toxicity? Again, almost where the acute toxicity was there. And this is after 2 years, you are already at the high point over there. So this genitourinary toxicity is going to play a very important role in your decision making when you tell the patient you are going to have bleeding after 4 years and it is going to keep on increasing till 12 years. Right? So if you see 120 months, 20% of the patients having genitourinary toxicity. All these, if you have prostate problems, you will have incomplete voiding, intermittency, weak stream, staining, and the list of and the percentages thereof. And this is the incidence of radiation cystitis. All these patients having radiation cystitis, I can vouch for the surgeons that once a patient gets radiation cystitis, he never visits the radiotherapy department again. He will come back only to you, and the radiotherapy people will keep thinking patient is fine, everything is fine. They will put it in their best result ratio, and the patient is slowly deteriorating over a period of time. The kind of complications which you get are insoluble. You can't just solve them. See the stricture rate. Once you get a stricture, the recurrence rate of the stricture, every 6 months, you are back at the doctor. Every 17 months, best of cases, every 2 years. You are back with the doctor. 15 years, 6 visits to the doctor for stricture urethra. And you have to pass urine 7 to 8 times in a day. Upar se you have got hemorrhagic cystitis and you have got your prostatitis. So look where the patient is descending into a quagmire over here. Bowel complications. So they tend to deteriorate over a period of time rather than improve. Diarrhea, fecal incontinence, rectal bleeding. And this is where I'll make my stand as far as radiotherapy is concerned. Almost for 35 of 84 patients with EBRT, acute GI events and late events, grade 1, grade 2, and increasing over time. The late and if you increase the dose, as you are increasing the dose, then the complications will also increase. So once the complications increase, the cost of managing the complications. So you have a high cost initially of radiotherapy, followed by high cost of management of the complications, high cost of RARP, all complications managed in the initial phase itself. So the long-term cost is definitely much less as far as early prostate cancer is concerned. So now what happens if you fail? You have given radiotherapy and PSA has reached nowhere near target. Then what do? There is nothing to do. You have to start the hormonal therapy. If you ask the urologist, he will take leave for 3 months and say, I don't want to do a salvage prostatectomy. I have done 2 in my life, they are healthy. And बाद में patient को आपको गालियाँ अलग से निकालता है क्योंकि incontinence and all those problems they occur separately. So you don't want to touch the patient with a bathroom when you are having a salvage radical prostatectomy. So these are the complications of salvage radical prostatectomy. This is one of the index cases. 63 years when he got radiotherapy done at UK. He was a T1C and 0, Gleason 3+4. Currently he is 79 years. Performance status is very good. PSA is undetected. But he has bilateral low radiatic strictures on JJ stand. He has a PCM on one side and he has multiple episodes of contracture. And just a couple of months back, I have done a urinary diversion and I have made a ideal conduit for this patient and diverted the urine to a bag outside. Next slide. Yeah. No, I didn't want the video. I wanted the last slide. The video is for Tejas, just to show him allergies sparing radical prostatectomy. There's a last slide of conclusion if I can get that. while the comparison between RARP, IMRT, brachytherapy will still be in its juvenile phase, because the time intervals, the first robot which incidentally came into Vedanta, which came in was I think 2008, and we got our robot in 2017. So it's too short a interval to comment on the results of radical prostatectomy, robot-assisted radical prostatectomy. We started our laparoscopic radical prostatectomies way back in 2007, 2006. We have some results, 10-year results over here. But I can tell you, they will not be inferior than radiotherapy, or at least, let me put it another way, radiotherapy cannot claim superior results as compared to robot-assisted radical prostatectomy. I can tell you that, one thing from my experience and also from the literature. This surgical option offers possibility of minimal medication. As many as 23% of the cases who were targeted to have ADT may not need it, which you had given in radiotherapy in any case. Complications of RARP over a 15-year period, which will be the expected cancer-specific survival of an early prostate cancer, will be less as compared to radiotherapy. They will be less both in incidence and in intensity. So even 80-year-old people can have good survival, and surgical option should not be denied to them. Salvage surgery after radiotherapy has poor results, so radical prostatectomy should be done prior to radiotherapy, even in multimodality treatment. This is a short video just showing you a radius-sparing radical prostatectomy as compared to the anterior approach, which I just showed you. This we go behind the bladder, enter between the prostate and the bladder, and then sort of reverse shell the prostate out. While Tejas was working on the floor all the time, we are working on the roof all the time. Most of the patients who come to us for a prostatectomy, they undergo a radius-sparing radical prostatectomy. In these patients, at least I can say for the continence bit, their patients are usually very happy with their continence after the first month or so. Thank you very much, and good luck to Dr. Shikha.
Thank you, Dr. Sobasus, for points in favoring radical prostatectomy. Please come to the dais. You sit over here. Now we'll call upon the second speaker.
So we have our second speaker. Now the beam balance has been shifted towards the surgery side. Let's see Dr. Shikha Goyal, who is a senior assistant professor in Department of Radiation Oncology, PGI Chandigarh. How she balances the beam or tilts it towards the radiation side. Let's see.
Good afternoon. I must congratulate Dr. Sobat for an excellent talk. Yes, it did give me a few things that I did not know or I was not aware of in that manner. And I think the most important thing to take home, no matter what the result of the debate is, that we should talk more to each other, we should understand what the other does, and we should at least listen with an open mind. Everything in surgery is not bad, everything in radiotherapy is not bad, and we should talk to each other more, and we should talk to our patients together and let them take the call wherever things are in the middle. So I'm speaking in favor of radiation therapy, and more than that, in favor of evidence-based medicine. So I've tried to have, despite the fact that it is a debate, I've tried to have not a biased talk from my end. So we know early prostate cancer is a mix of multiple things. These are typically prostate-confined, node-negative, non-metastatic disease, but usually clinical staging is not enough. Sometimes pathologic staging changes the clinical staging, and even with the clinical stage or pathologic stage, the risk stratification, the other factors such as PSA and Gleason score to give us more information in the presence of more adverse factors. Even in an organ-confined disease, the metastasis risk, the progression risks are higher. Some data is there on molecular profiling, but it is still not the holy grail, and it is still not recommended for everybody. So till we completely understand all of these, comparing treatments is something that is in a nascent stage. It is not something that we can give a stamp to at the moment. So we all understand as radiation oncologists that prostate cancer is a urologist domain. They diagnose, treat, follow up, and the patient's confidence in them will always be more than what will be there for a radiation oncologist from the time of diagnosis for their remaining life. But despite the fact that prostate cancer is the most common cancer in the world, we still do not have randomized trials which establish the superiority of prostatectomy over radiotherapy. It was easy to do. The numbers were never a problem, the cases were never a problem, but the mindset was never there. So how do you choose? If we have two equal options, then the choice will be based on other factors, whether it is A is feasible, B is feasible, whether the patient chooses A or B. If one choice is superior to the other and has low toxicity, then it's a no-brainer. The superior efficacy and superior lesser toxicity choice will be taken. But if A is superior to B but has more toxicity also, sometimes B would be preferred in certain situations. But for any rational choice, they should be compared under the same circumstances. You cannot give A to a specific set of patients, reserve B for another set of patients, and then try to compare how they do after 10 years or 15 years or even longer. So for radiotherapy and prostatectomy comparisons, the outcomes should have been evaluated in similar patient populations, and endpoint should reflect true benefit and not a biochemical surrogate such as PSA. Overall survival is not a good endpoint for early prostate cancer. Whether or not the patient is cured or not, the patient will live. Prostate cancer is not going to be a cause of death for the majority of these patients, and cause-specific survival or metastasis-free survival may be better options when we're looking at endpoints. So when the first discussion for a localized prostate cancer happens, the patient's concerns are whether treatment is necessary. If yes, then what treatment? Whatever treatment is chosen, what is the cure rate? What is the side effect profile for their treatment? If not treating is an option, then how do they follow up? What are the long-term implications of that follow-up also, and the costs involved. And the surgeon's concern, as Dr. Sopan had said, life expectancy is important. The patient's life expectancy is somewhat independent of the age. So that is dependent on the patient's morbidity profile and the physical status. So treatment decisions are based on that. But if a patient is treatable, then the option that is given is only radical prostatectomy. The other option is not discussed as an equal option. So it's a one-time process, agreed, it has minimum stay, agreed, patients can go on daycare basis on the same day also in robotic assisted procedures. Side effects, yes, he has considered that the treatment has side effects, but radiotherapy is a killer. Radiotherapy has huge side effects. Every patient of radiotherapy will have side effects. That is a mindset that you can change if you talk more to your radiation oncologists and to the others in the field. Cure rates with surgery are more than RT, yes, in all series, but I'll come to that in a while. If the patient is old or unfit for surgery, anyway, nothing can be done for the patient. So instead of not doing anything, you can send the patient to radiotherapy and see what they can do about it. So when we see a prostate cancer patient, whoever sees the patient, urologists are happy that they remove the patient, so the patient is rid of cancer. Radiation oncologists are happy that we killed the cancer, but we did not touch anything inside the body. Both have robots, so it is really not a fight of the robots. The only relevant roadblock in even evaluating whether one therapy is as good or superior to the other is bias. Of course, surgery saves more patient. Our surgeon colleague did say that earlier, and any publication will reflect his point of view. But it is a selection bias that has led to that publication reference also, because only patients who are fit for surgery undergo radical prostatectomy, and those fit patients will obviously have great survivals. There is a referral bias. Whoever cannot undergo surgery or do not want to go for surgery despite several consultations can try a less effective treatment at their risk because it is more toxic. So despite I've already told that it is the most common cancer, still we do not have a trial which is reflective of how one treatment does against the other in a randomized fashion, and we do not have any concrete data. The whole debate is on opinions rather than data. So shared decision making is not possible till shared consultations or tumor boards extend to all patients. I, as a radiation oncologist, was never trained for urologic surgeries. I have not witnessed a robotic or even a radical prostatectomy, my colleague would not have seen the steps of a radiation oncology procedure, the intensive effort that we do to help the patient such that we do not do harm to the patient. And there is comfort with our own specialty that is natural, but there is cynicism towards the efficacy as well as tolerance of the other modalities that comes out of ignorance rather than any other factor. Our toxicity evaluation criteria are different. Radiotherapy community will follow radiotherapy oncology toxicity criteria, surgeons will follow different toxicity criteria. We have our own publications. So it is never clear whether one will gel with the other. A common parameter has never been used. So patients will sense us, they do not go and read those publications. So they will side with the most confident doctors. Surgeons are definitely more confident doctors than radiation oncologists, that is hands down. But issues that should matter are related to the patients. All appropriate choices available for a particular risk stage should be considered, discussed in the interest of the patient, and these discussions should be based on the outcomes, which is cancer-specific survival, morbidity, short-term and long-term, as has already been stated in the procedure, the quality of life, cost, and as some people from outside radiation community also like to point out, radiation can cause second cancers also. But in prostate cancer, since these patients are elderly, second cancers are less of a concern because of the age factor and the lesser time available for development of these cancers. So I have already spoken most of these points, but yes, we have urologists who know what the radiation oncology procedures are like, but still there are concerns regarding how we go about it. The techniques have evolved. We are able to do much better radiotherapy delivery. We are able to give much better local control rates and thereby better survivals because we are able to push dose into the tumor without pushing more dose to the adjacent structures. We have a challenge. We are not able to separate physically the other structures from the prostate. So we will always have to deal with those other structures in situ. We know that radiation responses over time have improved with dose escalation, and these dose escalation strategies in the intermediate risk and high risk diseases have led to better survivals as well. And conformal radiation in the form of brachytherapy, as was discussed earlier, in the form of SBRT, protons, with image guidance has led to lower morbidity despite the dose escalation. We understand the radiobiology better. This has been a gradual process. So instead of giving 8-week long treatments, as was pointed out earlier, we are happily giving 1 week to 4 week long treatments, depending on the disease profile, the volume, the risk categories, and we are able to do a much better job, even without making use of technology there. So in good series, in independent good radiotherapy series, the survival is comparable to surgery. From good, I mean that the radiation technique was optimal and image guidance and appropriate dose was used. And with conformality, the toxicity that has been present is much lower compared to what it was reported in series which were reported 25 or 30 years back, which usually form the pivot of most of the debate discussions. The long-term effects with radiotherapy with doses between 70 to 80 gray, the radiation oncologists are notorious for noting even grade 1 toxicities. Toxicities that matter to the patients are severe toxicities. The complaints that would come would be at grade 3 or grade 4 toxicity. Those toxicities are typically less than 5%. So out of 100 patients that you send to a radiation oncologist, 5 people will come back to you saying that they had a bad problem. They may not want to go back to their radiation oncologist. For the rest of them, the problem is usually not as bad as to require a consultation, or they require minimal help and they are better with that. So radical prostatectomy side effects, the problems have already been noted, so I will not note them again. And we know that after case selection based on clinical criteria, the pathologic stage, the Gleason score, etc. Are affected by the PSA levels which are there at the outset before surgery itself. So these are the two main trials that were reported around 10 years back. These are the only randomized trials which have compared radical prostatectomy to anything. So even when comparing with watchful waiting or observation, mind you, it is not active surveillance where the patient is followed up very closely. These are watchful waiting or observation scenarios where the other arm gets palliative treatment when they progress. So even in those arms, the radical prostatectomy arm fared equally. So rather than doing anything, doing surgery does not help. Only in a small subset of patients who are younger than 65 years, one of the trials showed that radical prostatectomy does reduce the risk of dying from prostate cancer, but that graph also opens up after 6 years of follow-up. And this was reflected in a much longer follow-up as well of both these studies. This is one paper that is quoted widely where a huge systematic review was reported for radiotherapy versus surgery, included 19 studies, not one of them was a randomized trial. These were mostly registry data which took patients who had been selected for any criteria for surgery, any criteria for radiotherapy. Independently they have been seen and they have been compared. Only 6 studies reported both cause-specific and overall survival. 6 studies did not report cause-specific survival. These are massive data sets, 20,000 patients, 1 lakh patients. Still none of them is a trial. And there is an attribution bias because older registry studies did not know whether to attribute death to prostate cancer or not when they were reporting deaths. So although the reflection or the conclusion of this trial, this systematic review was that radiation therapy fares poorer, but we know that these are a conglomerate of multiple flawed studies and it is in itself a big flawed study. So if radical prostatectomy was not better than watchful waiting, how did it fare better than RT? In this meta-analysis as well. We know about the John West phenomenon. This was a company which sold fish and they had the tagline, it's only the fish that John West rejects that makes John West the best. So if you reject people that you cannot manage and you manage only the good chunk, then obviously you will have good data. Obviously you will have patients who will do well. So any surgeon would not take patients who are not fit for anesthesia. They will not take patients who are much older and on the cusp of dying or have multiple diseases. They will have more risks of complications. The younger patients will typically have lesser risk of dying from natural causes. And radical prostatectomy data would report pathological stage rather than clinical stage, even when upstage. So there have been several publications on cautioning against using retrospective data to inform treatment decisions. There are a few studies which have reflected this selection bias, even in patients more than 70 years. We can see in the above graph, that is the data for low to intermediate, and the lower graph, the data for high-risk disease. The black line is the cause-specific survival, and the orange, which is part of the chart, is actually overall survival. Overall survival will be difficult because of the selection bias, but cause-specific survival is not that different, at least for low to intermediate. For high risk there is a difference, but then there is a selection bias happening to it. And that is reflected in every publication, every meta-analysis. Even a meta-analysis like this which favors radiotherapy, I would say that there is a huge bias, and this is also not something that we should take home to counsel the next patient. So the PROTECT trial has already been discussed. This is the only trial that has compared surgery and radiotherapy and another arm of active surveillance. These were not patients who had presented with BPH symptoms. These were patients who agreed to come to a nursing clinic for a PSA evaluation. And subsequent to that, everybody with a PSA of 3 was offered a biopsy. Those who opted for biopsy underwent further testing and further evaluation. So out of more than 2 lakh patients who came for evaluation, of 82,000 patients who underwent a PSA test, eventually only 2,600 were eligible for the study and only 1,600 consented for the study, and these 1,600 patients were divided over 3 arms. So despite the fact that prostate cancer is a huge problem, this trial also could give us data only on 1,500 patients. And this trial shows that no matter whether you choose an active treatment or not, the cancer-specific survivals in the long term at 10-year follow-ups are not different. The cancer-related, the metastasis rates are slightly worse in the active surveillance arm. The deaths due to those metastases are there. They are higher than the treatment arms, but still in numbers they are not as high. So active surveillance is actually the recommended therapy now for low risk category. This is an ongoing trial where there are 3 arms. The first arm, which is the PACE arm, compares surgery and SBRT, and this unfortunately is the most poorly recruiting arm. So we don't know whether this will actually go to any conclusion. The other 2 arms are recruiting between radiotherapy techniques, and they have completed recruitment. This was a trial which was started for early intermediate risk patients. It was a non-inferiority trial comparing several treatments with surgery. Initial sample planned was more than 7,000. Unfortunately, they could randomize only 300 and they had to close the trial. So all of that I'm mentioning now is just to reflect the bias that creeps in even before we go to the results of therapy. This is a trial which is started by the Scandinavian radiation oncologist community. They have actually included radiotherapy ADT as the standard arm and are comparing surgery to this standard arm. But the data available till now is only the baseline data, and we know that these groups are well matched. So whatever outcome this trial tells should tell us which way to go for the high-risk patients as well. This is a patient information tool. This is something that patients are free to go to compare the outcomes of treatment that are available till date. This tool is not updated in 2022, but we can see that the longest follow-up is with surgical arm compared to external beam, but the efficacy rates are similar when good quality studies are reported, and this is true for all risk categories. So based on whatever data is available, whatever quality of data is available, the American as well as the European guidelines state that for low risk cancers, all treatments should be given an equal chance. Active surveillance should be recommended above a definitive treatment, and for intermediate risk disease, the favorable patients can still go for active surveillance. The unfavorable have a choice between surgery and radiotherapy, and equal choice. Here radiotherapy is not alone. Radiotherapy ADT of 4 months is given. So ADT of 4 months is not going to cause that much erectile dysfunction. ADT of 2 years when given in high risk disease, or 1.5 years now, is going to cause erectile dysfunction because of the effect of ADT. It does increase at the end of ADT period, but it does recover. Whatever erectile dysfunction surgery causes, it recovers in the first 2 years. Beyond that, the recovery is for a very small subset of patients or rather non-exist. So all the treatment algorithms within our country also state the same thing that the international guidelines have recommended. The toxicities have been discussed in detail. Earlier, I will not go to each of them independently, but just like to say that in the larger studies, the erectile dysfunction rate persistent at 2 years have been as high as 43%. The incontinence rates have been high initially, but they have improved to 10 to 15% by 2 years. So it's not a huge problem for everybody, but it's a huge problem for somebody who's presenting at 70, 75 or 80 years. That patient may be still fit for a radical treatment. That patient will live long. But that patient may live with the morbidity of this particular complication compared to not having to live with it. The urethral strictures are there for both. For radical prostatectomy also the rates are nearly 10% in open and lesser in the robotic assisted surgeries. For radiotherapy in the older data, similar rates of around 10%. The newer IMRT and LDR radiotherapy have given rates less than 3%, which are almost similar. So the toxicities are there, but if you magnify only the toxicities that are in the other modality, then you are biased. Then you are not able to give a fair answer to your patient as well. The PROTECT trial, these two dysfunctions, erectile dysfunction and the urinary leak, these were higher throughout the 6-year follow-up that they have reported. This is not a biased trial, so we can trust the outcomes of this trial at the moment. And the bloody stools and the loose stools are there more for radiotherapy, and that every radiation oncologist does conceive. The quality of life outcomes are also in keeping with these side effects. For salvage therapies, yes, radiotherapy after prostatectomy is possible. Surgery after radiotherapy is not possible. That is something that we hear from our urology colleagues every day. But then how many patients do need that salvage? For low risk, this salvage requirement in this trial, this is the result of the PROTECT trial only. For after radiotherapy, only 3 patients went in for surgery out of 603. From the radical prostatectomy arm, 108 patients went for the alternate procedure of radiotherapy after their surgery. And the survivals eventually were same. Cause-specific survivals eventually were same. So the need for salvage is more after surgery. It's not like salvage is not possible after radiotherapy and salvage is possible after surgery. So that should not be something that we should even discuss as the starting point. The cost would depend on technology. If we are both using advanced technologies, of course the cost of therapy would be higher in these centers. So cost is not something that we should base our discussion upon unless we are sitting in a place or the patient is in a place where they have to choose even between small differences in costs. So this is a graph or a chart of all the problems. I would not say that the problems of one modality are more than the other or one modality is superior to the other, but radiation therapy, even despite more than 100 years of experience in the field, more than 30 years of IMRT, is still trying to convince the other side that we can do a good job as well. We are as good and consider us equal, not consider us inferior without any basis. We accept the toxicities that our treatment causes. You accept the toxicities that your treatment causes, put them on the table for the patient and let the patient decide what they are most comfortable with. The toxicity rates are low for both techniques, but they are there for the patient who has it and they have a longevity. They will, for a patient who lives 20 years, those toxicities will matter. So the patient should know what they are going in for, honestly, and the patient should take a call on that fact. Regarding the contraindications, you have discussed that the LUTs will not improve the radiotherapy. Radiation oncologists do not claim that LUTs will improve. For patients who have LUTs or an intermediate risk, we happily send the patient for surgery, even if consult was given for radiotherapy and the patient was also more comfortable with radiotherapy. Similarly, the stricture rates would be similar for both. So just magnifying the stricture rates for the other modality because that is the only literature that we read is not a good idea. For low bladder capacity, we know that radiation will not do a good job. Even if the cancer goes, comfort will never come back. So those patients should go for surgery. So the case selection that happened earlier, you take the fittest patients. We also would take patients who are fit for radiotherapy, who will do well after radiotherapy and give them a good quality of life and a good lifespan. The lifespan would be equivalent to the surgery arm. The quality of side effects or the problems that the patient will experience will depend on the initial profile as well. So that is something that has to be made very, very clear.
Please.
So I've already said most of this.
No, it's okay, please.
The recommendations are there for low risk, intermediate and for high risk. Choices should be made by the patient and not by the doctor, but the doctor should honestly convey the choices to them. And the best technique available for that patient should be utilized regardless of the choice.
Okay, very good discussion, but we have to wait, please. We have to wait for few more years before results are coming because robotic surgery and there we are having IGRT, IMRT and so many advanced thing in radiotherapy also. And we have to see prospective study which can show the result. Then we can have okay, this is better or that is better. So without that prospective study, we cannot say at this moment which is better. Both are having good result.
I think Madam has justified her department more than sufficient. I cannot comment. From the word go, I'll concede that all surgeons are megalomaniacs and the patient does best in our hands and बाकी सब में गलत होता है, जो ठीक होता है हम करते हैं, जो खराब होता है बाकी करते हैं. I'll concede that. Second is the comment whether only healthy patients undergo radical prostatectomy. Yes. For Patrick Walsh, even if the patient sneezed in his office, he would reject the patient for radical prostatectomy and he would send for radiotherapy or alternative treatment, which was not very good. But that, I think that era is long gone. If even if patient keeps sneezing in the operation theater, we still do the radical prostatectomy in these patients. Regarding the complications, yes, the complications have decreased with IMRT and IGRT. We were talking about EBRT as the modality which is which is the modality which is mentioned in the guidelines, and against which the comparisons have been done, where the complication rate, because probably the technology was not as advanced as it was. But currently, yes, the complications are less. However, I will contest the intensity of the complication. You get a stricture in radical prostatectomy, it is totally different from a stricture which you get with radiation. This thing, you don't get a hemorrhagic cystitis or radiation cystitis after radical prostatectomy. I concede that the incidence might now be less because you are now doing such advanced techniques that might be there. You mentioned that there was no difference in the survival after between active surveillance and radical prostatectomy. I am sure there was no difference in the survival between active surveillance and radiotherapy also. You did not mention in both things. Right. Regarding the patient characteristics in the PROTECT-T trial, that is a matter of contention because they called, most of the patients did not turn up, only 1,500 patients turned up out of the 50,000 or so they called. And the quality of those patients, whether they came in for lower urinary tract symptoms or not, or they came for that was not clear from the study, whether they were exactly randomly. Did they randomly choose the patients? Yes. Did the patients come randomly? That was not correct. ADT given for any length of time will result in hypotestosteronism in majority of cases. So if you give it for 2 years, most of the patients will go into a low testosterone state, maybe 180 of that thing. So even if you give ADT for 4 months or 5 months, you are bound to have some kind of long-term effect with a low testosterone level. So last parting shot for madam is that I have a parachute in you, but be assured you don't have a parachute in me. I cannot do a salvage prostatectomy. I have had my experience with them. So with that, I thank you for the
Thank you, Dr. Swapna and Dr. Shikha. I think probably both sides have their points. I think probably it is the patient choice which matters. Ultimately, we are going to treat early prostate cancer, whether the patient wants treatment, whether the patient wants surgery, or whether the patient wants radiotherapy. Which type of facility are available in the near center, and that's the best thing to do. I think she rightly says it's a tumor board which has to decide about radiotherapy and radical surgery or no surgery, or no treatment other treatment. So with this, I think thank you very much. I would like to thank the organizer for the honor.
Thank you all. I would request the chairperson to please felicitate our speakers. Dr. Swapna. Dr. Shikha Goel. I request Dr. Sumit Jain to please come on stage to felicitate our chairpersons, please. Dr. Satish Jain. Yes. Dr. Avdesh Pandey. And Dr. Archana. Thank you all. We'll be continuing our discussion on prostate cancer, for which we have a panel. And I would request the chairpersons to please come on the stage. We have Dr. Meenakshi Mittal, radiation oncologist, Dr. Naveen Kanda, radiation oncologist, Dr. Puneet Bansal, Dr. Parvinder Sandhu, Dr. Deepak Abrol, Dr. Shabab Angurana. I request the chairperson to please introduce our moderator and panelists.
Good afternoon, everyone. After a lively, I think, an unresolved debate, let's move on to what we are doing in real life with a panel discussion on CA prostate. I invite our moderator, Dr. Sajjan Kakkar. He is an Associate Director, Radiation Oncology in Max Hospital, Mohali. And for the panelists, I invite Dr. Anchal, Radiation Oncologist from Patel Hospital. Dr. Tapas Dora, he is a Radiation Oncologist at Homi Baba Cancer Institute, Sangrur. Dr. Tejas Chiranjeevi, he is a uro-oncologist at HCG Hospital, Bangalore. Dr. Nishant Batra, surgical oncologist at Oswal Hospital. Dr. Ashwin Phillips is medical oncologist from CMC and Oswal Hospital. And Dr. Suresh Patel, medical oncologist at Patel Hospital, Jalandhar. And we have Dr. Gurvinder Singh, medical oncologist from CCA.
I'm sorry to interrupt, but I would request the chairpersons to please restrict to the time.
Panelists, I think.
Very good afternoon to all of you. Shall I start? So we have a radiation oncology dominance on the stage, so that is comforting. So thank you organizers for this opportunity. So in the interest of time, we'll start the discussion on the prostate cancer. Now prostate is a very wide subject, lot of deliberations and debate in each and every stage and risk stratification. I will be restricting myself to two cases, which we quite often see in our routine clinical practice. So our esteemed panelists have come here. So the first case is a 65-year-old gentleman presented with lower urinary tract symptoms, serum PSA 18. Thoroughly investigated with MR, prostate biopsy showed adenocarcinoma with Gleason score 9. CT abdomen, bone scan were done and they were unremarkable. So the patient was diagnosed at CA prostate, clinically stage T3A M0, high risk. So I would like a comment from our surgeons because mostly uro-oncologists, they tend to see the cases. Any further investigation is needed in this case?
With Gleason score 9 along with T3A, I would like to have a PSMA PET rather than a bone scan.
Okay. So is PSMA PET a mandatory investigation for staging?
According to the guidelines, NCC and recent guidelines and EAU guidelines, they say that anything intermediate unfavorable above, I think a PSMA PET would be a recommendation.
Any other comment, Tapas? Dr. Nishant?
Sir, yeah, you can do a PSMA PET, but as a routine practice in our institute, we never do a PSMA PET upfront. But especially for this case, I have never done and I would prefer not to do.
Yeah.
I also agree with Dr. Tapas, since all the investigations have been done and they are showing M0 disease, so I don't think even N is 0. So
Mostly we used to restrict PET CT scan for biochemical recurrences, but as Dr. Tejas rightly said, now the NCCN recommends to even do it in initial staging. It's not a mandatory thing, but yes, it can be done. And then the question comes, what type of PET to be done? Now there are a lot of radioisotopes available for PET CT scan. It can be fluoride, choline PET or PSMA PET. So I think PSMA PET is always the better choice. So let's keep the interaction lively. Any question, quick relevant question from audience also is welcome during the discussion. So let's come to the treatment options. So these wide variety of options I have given here. External beam radiation clubbed with brachytherapy, and external beam radiation with ADT, RP with plus minus adjuvant treatment, EBRT, ADT with abiraterone. So one by one, I will start from Dr. Nishant. So what is your choice? The patient has come to you, T3A, NCCN high risk. So what you are going to offer to this patient?
For this patient, sir, EBRT plus ADT.
EBRT plus ADT. So nice. Why? Why not surgery?
Sir, it's already high risk. So,
okay. Fine. Dr. Tejas?
Coming to the demographics of this patient, he already had a retention of urine along with the catheter in situ. So, going with radiation as well as an androgen deprivation, I won't be comfortable, because he might end up again with more of obstructive symptoms post-radiation. So I would rather think that better to go for a surgery, upfront radical prostatectomy and PLND.
Tapas?
It's again external RT and ADT, first one.
So patient has come to you and you are discussing in joint clinics. So how you will argue in favor of radiation?
Yeah, it's a long debate. Just now we finished. So of course there is a lot of confusion in this. But in our OPD, when we get a patient like this, we usually argue in a favor, like it's showing the touching the external capsule. So we say it's a chances of margin positive is absolutely there, and so in that case you may end with salvage radiation or adjuvant radiation, which will be more cumbersome. So it's better to go for a
radiation with ADT.
Though I am a radiation oncologist, but I will take this. I will send the patient to a urologist for radical prostatectomy, because he already has obstructive symptoms. So his quality of life with radiation is not going to be great after.
Coming to the medical oncology colleagues, any data to add abiraterone along with ADT and EBRT? Basically in Stampede it was more for a very high risk patient. Yes. So yes, abiraterone can be added as per the Stampede data what we have in this case. So already we have discussed in the debate, I'll not take it into further details. So RP versus RT, you don't have any conclusive evidence. There's mostly heterogeneity in data, non-randomized data. One Scandinavian RCT is going on, and by 2027 probably we will have some early results. Protect T already we have discussed, so I'm not going into detail much in interest of time. Recently, the John Hopkins, they published their retrospective data from SEER database, almost 24,000 odd patients of NCCN high risk. So they evaluated RP versus RT, and what they found is that cancer-specific mortality is low in radical prostatectomy as compared to radiotherapy. But again, a retrospective data, a lot of bias involved, so we can't take it on the face value. So, but as Tapas told, there is no consensus for optimal treatment in high risk. We need to individually decide what patient will fit for RP or for radiotherapy. So coming to the radiation oncologist, Dr. Anchal, what would be if the patient is taken for radiotherapy, though you have told RP is better, so what would be the dose and fractionation?
So,
any ballpark figure you can say this much dose at least should be given?
So moderate hypofractionation, this is N0. So like what we follow in a hospital is we give 70 gray in 28 fractions at the rate of 2.5 gray per fraction. And prophylactic nodal irradiation in this patient, sorry, you did not mention the age of the patient.
Age is 60, 65, it was mentioned.
Okay. And PSA was 18.
18.
So I would give prophylactic nodal irradiation.
Any comment?
Yes, sir, there is no confusion in this. We will go for a 68 gray. We usually give in 28 fraction for the prostate. And the recent properties trial has given the proof evidence to go for a whole pelvis RT for any high risk.
So prophylactic nodal radiation should be done in high risk and very high risk.
100%.
That's a message for the audience, should be done. So any role of focal, Sushovan just mentioned Flames trial which was published last year and it was updated last month also. So there the authors, they have given intraprostatic to the lesion, they have given boost, simultaneous integrated boost to the tune of 95 gray. the whole prostate received around 80 gray equivalent dose and 95 gray went to the prostatic lesion. So what is your take on that?
We don't do any intraprostatic boost as such. When we do a contour on this case, we of course we fuse the MR along with our planning CT, but we draw the whole prostate along with the seminal vesicle CTV and generate a 7 mm margin, 5 mm posteriorly to generate the PTV. But if we do like you are saying in this trial, we need to draw the GTV inside the MRI and we need to boost it. We are
Still
not
quite early to, I think,
yeah, still quite early. But even if with the 68 gray and 28 fraction, it's I think the bead is going nearly 120 gray or something, so that's well enough to control the work.
Coming again to my medical oncology colleagues, so castration, whether it's surgical or medical versus combined androgen blockade. So what you prefer when a patient non-metastatic prostate cancer comes to you, and LHRH agonist versus antagonist. So there is another confusion ki what to choose. So,
sir, I prefer combined androgen over castration.
Okay.
Because many of the patients refuse for surgery. And regarding LHRH agonist versus antagonist, it depends on the patient's status and also whether he has any cardiac morbidity or not. In case of cardiac morbidity, I go for antagonist-based therapy. And if patient doesn't have any cardiac morbidity, then I go for agonist.
so efficacy-wise, both are similar, I think. Agonist versus antagonist.
One antagonist will have a quick action.
Quick action.
And otherwise.
So this patient underwent robotic radical prostatectomy. The histopathology is as follows: adenocarcinoma, Gleason score 9, focal extraprostatic extension was present, bilateral seminal vesicles free, apical margin was positive, rest of the margins were free, all node negative. So carcinoma prostate PT3A, Gleason score 9, R1 resection. So where do we go from here? So anything, I just again from my surgical oncologist colleagues, any role of neoadjuvant ADT before surgery?
Yeah, we've been doing neoadjuvant hormone therapy for especially for high risk, very high risk and locally advanced prostate cancers. So there was a meta-analysis mainly published by the Korean group, which said that the surgical positive margins is reduced by almost 23 to 24% by giving a neoadjuvant hormone therapy, be a single drug or maybe a combination of antagonist as well as blocker.
So giving ADT and having a fibrosis, they are intraoperatively, it's fine?
Intraoperatively, when you give either abiraterone, it causes an intense apoptosis. So we do see sometimes all the, so especially the seminal vesicles and all, pretty much stuck to the bladder. But since we're doing robotic surgery, it can be taken care of. And also we try to go as a wide margin of excision beyond the denon-villus fascia. So we are going to publish that paper which says that our positive margins by doing neoadjuvant hormone therapy and surgeries have definitely come down when you compare with without neoadjuvant hormone therapy.
Okay. Dr. Nishant, Dr. Suresh, any comment on the neoadjuvant ADT before RP?
We don't usually find operable prostate cancer.
Okay. So we have some data. So there are a lot of, as Dr. Tejas just pointed out, a lot of phase 2 data is there, which has compared not only the ADT, even chemohormonotherapy has been compared. Pathological outcomes have improved, as you rightly suggested, but clinical outcomes still they have not shown any benefit right now in the phase 2 studies. A phase 3 trial, a Proteus trial is going on. Maybe it will give us some answers. But quite interesting or intriguing thing in these studies are they have not compared with the control or standard of care. That is no neoadjuvant therapy versus neoadjuvant therapy followed by RP. All these studies, they have different combination of ADT. That is LHRH analogs with new anti-androgen agents. There is no control standard of care in all these studies. So basically all of them are comparing different combinations of neoadjuvant ADT before RP. But future will tell us. Right now in routine settings, it's not recommended to do preoperative ADT before radical prostatectomy. So coming to another interesting issue, post-prostatectomy radiotherapy. Now whether to give immediate or that is adjuvant
radiotherapy or a salvage treatment. So I'm just more a proponent of a adjuvant treatment in clinically indicated cases rather than going for a salvage. But yes, I would like to hear from you. So patient has come to you with the report R1 resection, GS9, seminal vesicles free, focal extra prostatic extension. So what you will suggest to the patient?
All the points favor for high chances of recurrence. But again, if you look at the radicals trial and RAVES trial, which says that adjuvant radiation therapy has more of complications when compared to salvage. So in such condition, if the patient has, I don't know what was the margin positivity, whether the margin positivity was more than 3 mm or less than 3 mm, whether that focal positive was had a Gleason score of 4. If it was a 4, then it becomes a very high. So I would rather start with the androgen deprivation therapy for few months and then go for a salvage, because post giving an adjuvant will always have more complications than a salvage.
Okay. Tapas?
I agree with the same proposal. I also prefer for a salvage radiation instead of the upfront. I will monitor the PSA, how it's going, and we can.
So all patients you just monitor as a protocol, or there are some patients where, as suggested, you may opt for immediate radiotherapy?
There are cases. If it's a really gross R2 kind of thing, I would go ahead. It's a focal margin positive, so I think I can keep.
Any comment, Anchal?
See, focal margin positivity we can observe also.
So we just talked about radicals trial. So initially the old data what we had is this was comparing post-op RT with observation, and always it was said immediate RT is better. Then in 2020 we had radicals, RAVES, and the French study and its meta-analysis also, which got published. Now these three trials clearly showed there is no difference whether you give immediate post-operative radiotherapy or salvage RT. But what I want to point, this is another matter of debate, but what quickly I would like to point out, if you see the patient population in these trials, there were quite low risk patients which were accrued in all these protocols. If you see in this radicals RT, Gleason 7, 3 plus 4, 50% of patients were taken accrued. If you see a pathological 2-stage, quarter of the patients, they were pathologically T2. Coming to the other trials, Gleason score 7, 80%. The third study, if you see seminal vesicle involvement, not involved 80%. So probably a very low risk cohort was accrued in these randomized trials, and probably the benefit, the patient cohort which would have benefited from the immediate RT missed the opportunity. So that is very important to see. The patients accrued in this were quite low risk, and hence the missed benefit in the Gleason score 8, 10, PT3 or higher, which probably would benefit for immediate radiotherapy. Second is the endpoint. So they have taken as progression-free survival or metastatic-free survival as the primary endpoint, which probably is not right, because some of the studies, they also allowed ADT to be used. So once ADT is coming in the picture, then PFS is not going to help. So OS probably is a good surrogate, but they were not powered enough. They were in between, the trials were closed when they saw there is no difference between the two arms, or the longer follow-up is still not there. So probably there is some patient cohort which will benefit from immediate post-operative radiotherapy once the patient has recovered from the side effects of RP. In this regard, there is another study by Tilke et al. It's basically a multinational pool data. Almost 20,000, 26,000 odd patients who underwent RP were evaluated. With adverse pathology, as I mentioned, GS 8, 10, PT3 or higher, there were almost 2,400 patients. Amongst them, node negative were 933. So these patients, when they evaluated RT versus no RT, what they found in this cohort of patient, adjuvant immediate RT led to reduction in the all-cause mortality as compared to salvage RT. So probably there is a cohort with GS 8 to 10 margin positive, where probably immediate radiotherapy will show its benefit as compared to the salvage form. So again, coming to Tapas, we have some different risk stratification scores available nowadays. Oncotype DX, even in prostate, we have Decipher. So do you routinely use them in your clinical practice? No. Okay. Any other comment from our medical oncology colleagues or surgeons regarding this scoring? So actually this CAPRA score is quite a validated score. It was given by UCSF and it was validated internationally also. It's validated for both surgery, radiation as well as ADT. In our clinics, we tend to use CAPRA-S score, that is post-radical prostatectomy, to see what is the risk of biochemical relapse or mortality. So basically, pre-operative PSA, margins, seminal vesicle, Gleason score, ECE, and lymph node involvement. So our case came as CAPRA-S8. So anything above 7 is basically high risk and should go for immediate RT, as sir suggested, rather than putting him on the observation. So our patient, so which we were discussing, I will be a bit fast. So at 1 month post-surgery, PSA was 0.2. 3 months later, it was 0.4. So PSA never came down to undetectable level. So what next to be done? The surgeons, please.
At this point, I would like to do a PSMA PET if I am allowed.
Yes. So PSMA is not showing any disease.
So we do know from the pathology that there was a positive margin, probably higher margin. So I would like to put them on hormone therapy followed by radiation, because if the PSA jumps to 0.5 or 0.6 or up to 1, the chances of metastasis is very high because it's going high risk.
So the purpose is that sir suggested 0.5. So what is your trigger level? At what level post RP PSA you think RT should be initiated?
2 rises will be there, definitely will go.
Yeah. So as the data says, anything above 0.2 or more, we should initiate the treatment at the earliest rather than waiting, because it affects the outcomes. So this patient then underwent, as rightly suggested, he underwent ADT was started, followed by radiotherapy to prostate bed, and it's almost 4 years post-treatment. He's doing well with some post-radiation proctitis, which is now he has recovered from that. So coming to the second case, 80-year-old gentleman, he was diagnosed as CA prostate, Gleason score 10 in his native place, and underwent orchiectomy. After that, for 1 year, no further treatment was done, and patient was symptom-free, never went to the hospital. Then in March this year, he had lower backache, orthopedician operated for disc prolapse, but still the pain continued. His PSA in February was 4.6, which went on to 138 when he approached in our clinic. So MR spine and PSMA PET CT was done, which showed disseminated skeletal metastasis only. So there were multiple skeletal metastases throughout the body. So now we have a castration-resistant metastatic prostate cancer with us. So coming to Dr. Suresh and our medical oncology colleagues, what next should be done? Any other investigation or test you want before starting the treatment?
I would like to do even a echo and
Yes.
biochemistry. If echo is normal, then I would like to go for evidence.
Any role of biopsy of any metastatic lesion? Is it indicated?
Biopsy, usually many of the patients refuse for biopsy, but preferably for him I would not go for biopsy because he has only skeletal metastasis.
Okay.
So doing biopsy from bone lesions is difficult. So my option will be to go for abiraterone based therapy if echo is normal, or if echo is abnormal, then I will go for enzalutamide based therapy. I would also like to do germline HRR.
Yeah, that's what I just wanted to ask. Anything germline, how they help the germline testing and somatic mutation testing?
We can get options. It has two benefits. If the germline testing is positive, then we can also recommend for amnesty. One thing. Second thing is we have options like PARP inhibitor based therapy.
Yes. Yes. So NCCN also recommends, it's there in the guidelines, to always do a biopsy if possible, especially for a metastatic lesion, to get the germline mutation. Even it's not only metastatic, even the guidelines recommend it for very high risk and high risk localized prostate cancer also to do a biopsy for this germline testing, as he rightly suggested, for treatment selection as well as for screening of the familial risk in the family. So various mutations in these recombinant repair genes like BRCA1 and 2, ATM and so on, these are recommended to be done. And as rightly suggested, PARP inhibitors, olaparib has come in a big way in these mutated, if the repair genes are mutated. Pembrolizumab again is used as immune checkpoint inhibitors. Patients who have BRCA2 mutated cancers, platinum-based chemotherapy work well. So these are some of the recent advances which have happened in the patients who develop metastasis. So a biopsy should be done if possible. So the treatment options we have already discussed. So ADT alone, abiraterone, and the newer anti-androgen. So when you use chemotherapy in such patients, ADT along with chemotherapy.
So if patient is not having any wisdom.
Yes.
And he is also elderly, so we would go better with the abiraterone or enzalutamide.
Yes, so toxicity is the major concern. Yes, so we have different trials. I'm not going to detail of them. So one thing I wanted to ask from you, abiraterone, what's its association with food? And even now the clinical oncologists, they are recommending not to give 1000 mg per day. Even lower dose is also equally effective, like 500 mg. So what is your take on that?
Phase 2 trial was actually CRPC, so where they compared 100 mg standard dose, 1000 mg with 250 with a low fat dose. So this was PFS, and it was just that PSA control rates was similar, and on that they have a take-home message that we can use 250. As Viratron has on its side effects of basically fatigue, edema, then you can so many people are now using 250.
So it's being used in our routine practice? Okay. So I think then there is another combination, ADT with abiraterone plus docetaxel. I think the phase 3 trial is going on. We may get the answer. It has come? Okay.
So they have shown a definite survival benefit with triplet as compared.
Okay, but toxicities?
But he's not an active.
Yes, age.
So that means 60, 65.
Yes. So now the patient was started on abiraterone and prednisolone. Palliative RT was given to the lumbar vertebra as well as S1, S2. So now coming to the role of local treatment, whether it's prostatectomy or radiotherapy especially. So coming to Tapas and Anchal, what is the role of prostate radiotherapy in metastatic settings? In a castration-resistant or a newly diagnosed de novo metastatic prostate cancer?
So we would prefer to complete the full dose of initial palliative chemotherapy, then repeat a PSMA PET to see the burden of disease, and if it has really gone down from the metastatic sites, especially this bone mets kind of thing, then we can think of, according to Stampede, if it's N0, we can go ahead for 55 grade 20 flexion.
Any comment, Anchal, surgeons, sir?
Only if there is a oligometastatic residue after the completion of abiraterone based.
Yes, so as you rightly said, Stampede has shown, this was a randomized, Stampede is a multi-stage randomized trial which is going on. So initially when they gave prostate RT to all metastatic, de novo metastatic patients, so there was no benefit, no OS benefit. But when they saw, as per the charted classification of dividing it into low risk and a high risk metastatic group, so patients with low volume metastasis, they showed significant OS benefit with prostate RT, that is 55 grays in 20 fractions, or hypofractionation 6 times 6. So after that, even the meta-analysis of Horat trial and Stampede showed there is absolute improvement in 3-year OS to the tune of 7%. So prostate RT is definitely recommended. Any idea about the metastatic directed therapy? Local treatment to metastasis, be it surgery or radiation?
With this kind of skeletal mets all over the body, it's quite difficult, but if it's a real vertebral mets, L3, L4, some solid.
That is palliative RT.
Yeah.
So I'm not talking about palliation. Asymptomatic metastasis. So whether you would like to give radiation to that?
Bone mets are
whatever be, bone, liver, lung, wherever it is.
Less than 3 sites we can take it.
So there is some data that if we give metastatic directed radiotherapy, we have phase 2 trials, prospective trial, ADT-free survival is better. If we see the evolutionary history of metastatic prostate cancers, so the seed and soil theory, which everyone has learned about, so it's not only the prostate primary which throws metastasis, even the metastatic sites also throws metastasis. So it's always the premise is to even treat metastatic sites, but still, yes, it's still in the protocol settings. Further trials are going on. It's routinely not recommended to do metastatic directed therapy in prostate cancer, but yes, now the data is coming up for this also. So with this, I would like to complete my discussion. Any questions from the audience? Welcome. Any final comments from our panelists regarding these cases, high risk or metastatic prostate cancer?
It's a reality. We never gave importance to the bone health.
Yes.
So that has to be.
That has to be.
So, Dr. Sajjal, I just had a few queries to the surgical oncologist. So it's proved beyond a point that if you do neoadjuvant hormonal treatment before radical prostatectomy, there is a lot of fibrosis and there's difficulty in doing surgery. So the fibrosis is going to stay whichever technique of radical prostatectomy surgical you use, either it's a robotic or it's a laparoscopic or it's an open technique. So you use neoadjuvant hormonal treatment for these patients. Like the first patient I'm talking about, it's 3-3, high risk.
So initially we started with the locally advanced prostate cancers because the locally advanced prostate cancers with age less than 60 or up to 60 years of old, we used to give neoadjuvant hormone therapy. There was a meta-analysis data for LAPC. So the same thing has been corroborated for the high risk. Right now we are using for high risk for probably
so is it like a standard of care at this point?
No, it's not a standard of care. That's what I would say. It's not a standard of care.
Absolutely. Because I just wanted, if the students are there, they should be knowing it.
It's not a standard.
That's what we mentioned. It's not a standard of care.
Yeah.
But
So the
trials are
second,
going.
so the second thing is, do you use in these patients adjuvant hormonal treatment also later on?
It all depends upon the final histopathological report.
See, your stage is not going to change. You had a patient who was very high risk.
Yeah.
I'm talking about this particular case.
Okay.
See, the reason why I'm trying to talk to you about all these things is because there's a lot of discussion on whether we do for external beam radical radiation treatment, should we do radical prostatectomy, and then there was a role of doing a salvage radiation treatment or upfront radiation treatment. So what I am trying to tell here is that the standard of care for these patients is definitely adjuvant hormonal treatment or hormonal treatment plus a radical radiation treatment. When you see this patient and you plan for a radical prostatectomy, you know that the patient is high risk and there's a chances of getting a positive margin or a high risk histopathological findings in these patients.
It also depends upon before going for surgery, whether the MRI or the PET CT was done immediately or how many weeks of gap was given.
See, usually when you make a diagnosis of a patient, you take the patient for treatment. We as a radiation oncologist also take it like just 4 weeks of the MRI is done, and if it's more, then we do repeat the MRI scans here. So I am just talking about this particular patient. I'm not talking any other situation. So my rationale was, you are doing a radical prostatectomy. You give a neoadjuvant treatment for these patients. You're trying to reduce the size of this thing. Then you're going to get a lot of fibrosis. The surgical will be difficult. Then after that, you will need salvage or an immediate radiation for these patients. Now your question was that if you do radiation in an adjuvant setting at that point of time, it causes radiation toxicity.
Yes.
It causes more of complications.
Yes.
See, when this patient can be alone be treated with a single modality of treatment, that is a radiation radical treatment and hormonal treatment, and the patient has the chances of curability of disease, then when you're doing two treatment modalities for these patients, and that radical treatments, you're doing a radical prostatectomy, I'm giving a post-op radiation treatment also. So these patients are bound to get more of complications, but still, those complications are not to the tune of that the quality of life of these patients will be hampered, or long-term toxicity is going to be, not getting relieved of.
So I think what Dr. Shabab wants to say is,
Yes,
I think
see,
better to
Yes,
take a holistic approach. It's not a debate or fight between RT versus RT.
What
So
I'm
it's a
trying-
holistic approach.
What I'm trying to say is,
use the
there is-
prognostic
Yeah,
scores.
I agree, sir. But in this patient, there were two factors which I would like to put in for a radical procedure, because one, it was a high risk and a high grade. It was a Gleason score of 9. The second thing was the patient came with a retention of urine. So these 2 points are bound to have recurrences post-RT.
So once you have a patient with the lower urinary tract symptoms, you start with the neoadjuvant hormonal treatment for these patients, which relieves the size of the prostate, which relieves the lower urinary tract symptoms also, and then you start with radiation treatment also. So this is the see what I am trying to tell you. This is the
standard of care. What
See,
you say?
we are putting one patient who can have a standard of treatment care. We are putting them to more than 2 radical treatments. We're getting more of complications, and we are compromising with the long-term survival of the patient also. Isn't it? See, once you have a patient who is high risk and very high risk, you know that this patient will need radiation treatment later on also.
I think Shabab, I think we should take it to by the next during the lunch. Want to continue?
Never ending debate.
Thank you all the panelists and chairpersons. Thank you.
Thank you, sir. I request the chairperson to please felicitate our moderator. I request Dr. Shikha Chawla to please come on stage to felicitate our chairpersons. And Dr. Jagdeep to felicitate our panelists, please. Dr. Meenakshi Mittal. Dr. Purvinder. Dr. Gurvinder. Dr. Purvinder Sandhu. Dr. Deepak Abrol. Dr. Shabab Angurana. Dr. Anchal. Dr. Tapas Dora. Dr. Tejas Chiranjeevi. Dr. Suresh Patel. And Dr. Nishant. Thank you all. With this, we come on to the last session of the conclave. And we have in this session bone marrow transplant in hematological malignancies. For this, I request the following chairpersons to please come on board. Dr. Sonia, Associate Professor, Immunohematology and Blood Transfusion, DMCH. Dr. Sunny Jandial, Medical Oncologist, Jammu. Dr. Yogesh Arora, Senior Medical Oncologist, Oswal Hospital. I request the chairperson to introduce our speaker, Dr. Suvir Singh.
So the last topic of this oncology conclave is overview of bone marrow transplantation and DMCH and AI experience of bone marrow transplantation in hematological malignancies. This topic will be presented by Dr. Suvir Singh. Dr. Suvir Singh is Senior Consultant in Clinical Hematology Oncology and Stem Cell Transplantation at DMCH Cancer Care Centre. I invite him and welcome him to start his presentation.
So good afternoon everyone. So this is the last session before lunch, so I won't burden you with a lot of statistics and data, but I'll just give you a short overview of what PFT entails and what has been our experience starting this as a new service 2 years ago in DMC. So BMT is a potentially curative approach, and it has developed slowly over the last 40 to 50 years. And now the BMT activity is rising worldwide. We have more than 30 to 40,000 transplants performed in single countries, and even India has reached a mark of about 20,000 transplants a year in the last 2 to 3 years. And over the last 60 to 70 years, we have gone from definition of B cell and T cell to using these cells for therapy by using CAR T cells in cellular therapy. So stem cells have a unique property, and this is very important from a patient point of view, that the cells actually can just hone into their niche in the bone marrow, and you really don't need to train them to do that. The stem cells circulate in the blood. Everybody has normal circulating stem cells in their blood. And when you infuse it into a patient, they will automatically go and fill the niche and start functioning. And this is very important because we infuse the cells IV and they automatically find a way in the stem cell niche. This is a definite anatomical area below the periosteum in the bone marrow. And this is where the stem cells are known to function. The second important thing about transplantation is in malignancies, we utilize a graft versus leukemia effect. This is very, very useful in allogeneic transplants. So patients who are not responding to any form of therapy, the GVL effect or the graft versus leukemia effect is something we rely upon. And this is the cells of the donor which act against the leukemic cells and the leukemic stem cells. And this is responsible for much of the efficacy seen in stem cell transplant. The indication for transplant have stayed almost the same over the last 20-30 years. The black one, if you see, are the autologous transplants. Worldwide, the most common indication is multiple myeloma, and followed by relapsed lymphomas. And for allogeneic transplant, the commonest indication worldwide remains acute myeloid leukemia. This is Indian data which was shown last year, and if you see, the number of transplants has been steadily rising. And now we are doing about 2,000, 2,500 transplants per year in India, and this number is gradually going up with the addition of new centers. If you look at the indications, these are the ones in red are the commonest indications, and they probably form over 80% of all the transplants that are being done. For myeloma, it is, as I said, myeloma and relapsed lymphoma for autologous transplant, and acute leukemia, aplastic and thalassemia for allogeneic. This is reflected in the Indian data. If we see, so the myeloma continues to be the commonest indication of transplant, followed by leukemia and thalassemia. An important thing, development which has happened, and it is helping us also quite a bit, is the availability of matched unrelated donors. And this is gradually becoming more and more accessible to a lot of patients owing to cost and better logistical support. So basically we have a number of registries in which voluntary donors can register, and if you have a match with your patient, you can always ask for the donor to donate the stem cells for your patient. These are purely voluntary donors, and the registries actually take care of the whole logistical issues. We also have a couple of registries which are functional inside our state, so a couple of voluntary organizations in Punjab itself who will do a search locally and will be able to provide you stem cells if they find a match among their registry. So this we saw during COVID. This is during peak COVID, during the first wave. We were able to get stem cells from DKMS for a patient, and they managed the whole process, including flights and transfer of cells and going through the customs and everything very smoothly and efficiently. The third important thing, which is probably one of the most important, is that we usually, the typical older way of looking at transplant was that you give high dose chemotherapy or radiation to kill off all the stem cells that are there in the bone marrow. But now we have more targeted and more and less toxic regimens which can be used. Initially, we only used to use total body radiation, but now we have low dose of total body radiation in combination with chemo or low toxicity chemotherapies, and this has increased the accessibility and applicability of transplant to more older and lesser fit patients. So if you see, this is just an example of the type of chemotherapy conditioning regimens that we can use, and it is along the spectrum. You can use more toxic regimens, these are the older ones, and you can use regimens which are less toxic but have a similar efficacy. So flu and triosulfan and fludarabine and melphalan have something which have made a great impact in patients undergoing transplant for acute leukemias. And this has also changed the demographics. We are now seeing more and more older patients undergoing transplants. In fact, in our center for myeloma, we have taken several patients above 65, 67 years of age, and they have tolerated it quite well, probably because of improvements in supportive care. Stem cell collection, so this is just to highlight how teamwork is so important in conducting a transplant. It's not a single person, not a single department. It is just a result of teamwork that we are able to do this smoothly. So stem cell harvest, we can get the stem cells from either the peripheral blood or the bone marrow. And the most common source that we use are peripheral blood stem cells. Bone marrow stem cells are used for very specific indications. So peripheral blood apheresis is now purely under transfusion medicine in our institution. And this is just like somebody going to donate blood or platelets. It's a 4 or 5 hour process, and we're able to get quite good yield with our setup. So these are different machines which are available. Each of them have separate properties, cost to the patient, how they function. So, and it's very important to have a single machine, get used to it, get used to the problems that we're going to face with that, and have a person, a contact person or an engineer ready at hand who can come and take care of any acute problems which will happen. So we are able to get quite good results with this machine. We even, in fact, were able to do a apheresis for one of the youngest kids in the country. He weighed about 6.5 kgs, and that was reported in one of the papers last year. The second way to get stem cells is by bone marrow harvest. This is a process under general anesthesia. So you've seen a bone marrow aspiration being done. This is the same process, but 2 people are doing it, and you collect almost 800 to 900 ml of aspirate from the bone marrow. So this has to be under general anesthesia, and because you're taking so much blood from there, the blood group has to be matched, and a lot of specific things have to be checked. So anesthesia, blood bank, pathology, hematology, everybody has to be on the same page when this process is being planned. Now, donor typically doesn't need to be admitted, but sometimes if you have a child who is a donor, they may be admitted for a couple of days just because a marrow harvest is under anesthesia. So this again highlights the importance of how important it is to get the fitness for the donor, and the rule being that the donor can never be harmed. We cannot have a situation where the donor is undergoing problem because of the stem cell donation. So this is a very, very critical part of the whole process, and the donor may need to be admitted for a couple of days if it's a GA harvest. The third important thing which we are able to start is stem cell cryopreservation. Any chemo that we give for more than 2 to 3 days, we definitely need to do cryopreservation because the cells will lose their viability and may not function. And we have started it in-house using a novel system in liaison with the company. So this is a closed system in which multiple bags are put in line, and there is absolutely no contact with the outside environment. So it's an absolutely sterile procedure. We reported it in the Asia Pacific BMT conference 2 years ago, and we have obtained very good results with it. And this also transfusion medicine is taking care of now, and we've been able to bring the cost down quite a bit. When we thaw the stem cells after maybe 7 days of chemo, we usually get a viability of more than 80 to 90%. Infrastructure is again a very important part of any transplant unit. So, for example, mixing chemotherapy, doing cryopreservation, everything is inside a sterile setting. So this is a biosafety cabinet which we had to install inside BMT, and all the processing of stem cells, the cryopreservation, depletion, or mixing of chemotherapy, everything happens inside a sterile area. Then the transplant basically is just an act of stem cell infusion. We connect the bag to the patient, infuse it over about 2 hours, and from now on, it's basically a waiting game, because by now the high dose chemotherapy or radiation has been given. The patient is grossly cytopenic, his total count may be about 100 or 0. And at this time, this is the time when all the complications will happen. So we have to look for infections, anemia, bleeding, veno-occlusive disease, fluid electrolyte imbalances. And this is a period of about 7 to 10 days, which is the most critical. And this is where teamwork and staffing is very important. So children have to be kept entertained, because a child will be locked inside the room for about 15 days. And this is very important to let the children use laptops or tablets or whatever. Because it's a difficult process to sit inside for 2 weeks at a time. Food also, so this is an Indian kind of adaptation of Jugaad. So because of high rates of infection, we have been giving food through which is terminally pressure cooked. So whatever food is available, it's put in a tiffin. We put it in a pressure cooker, give 1 or 2 whistles, and it is opened only once it reaches inside the BMT. And we've never had a problem with foodborne infection in these patients. We do allow any packed food, so like you see this child eating chips, so that is absolutely allowed, and that is important, because when they get mucositis, you have a lot of difficulty with taste. The patients don't want to eat anything, there's a lot of nausea. So you allow them to eat chips or chocolate or ice cream, whatever, so just to keep the patient's spirit high. This is a 1 to 2 week process when infections, everything is kind of on an emergency basis. So this is part of the protocol. So earliest sign of infection, we have to start antibiotics. a CT has to be done if the infection was settling for a couple of days. Transfusions have to be done according to protocol, and this is the whole reason why it is such a high risk process. But depending on the intensity of chemo that we give, the cell recovery will take place at a different time. If you give a very hard, intense chemotherapy, the recovery and the engraftment might happen within 2 weeks. But if you give a reduced intensity conditioning, the cells will take time to go down and will take more time to come up. So the patient may be inside BMT for more than 3 weeks while using a reduced intensity regimen. And once the platelets are more than 20,000, ANC is more than 500 without any support, we usually start tapering on the antibiotics, and at this time the patient, usually if he is afebrile and taking orally, the patient is made ready for discharge. And this is when all the major problems happen. So one of the most important problems that we face is graft versus host disease, and this is because of HLA mismatch between the patient and the donor. And acute GVHD is the most important serious complication that happens in the first 3 months of transplant. And this is something which is not going to benefit the patient in any way, and we have to make all efforts to stop acute GVHD as much as possible. Chronic GVHD usually happens after 3 months, and this is in a way beneficial to the patient, because if you have chronic GVHD, that indicates there is a graft versus leukemia effect also functional. And some chronic GVHD will always be helpful in preventing disease relapse in these patients. And this is also an emergency, because if you have a severe chronic GVHD or any grade of acute GVHD, you have to start immunosuppression and make sure that it doesn't lead to endowment damage, because this can be life-threatening, especially because the first-line medication is steroids. In patients who are steroid refractory, there is absolutely no data on which is the best medication, what best approach to take after that. It is just empirical and varies from center to center. So after the transplant is done, we check chimerism. So this is basically to see when the patient's counts have come up, whether it is a patient's own cells or are they the donor cells. So we usually get a result in percentage, what is a percentage match in the chimerism post-transplant. And ideally we want 100% of the donor cells to be present. In a patient, when we give a reduced intensity chemo, the patient's own cells will take some time to go, so it can take up to 2 to 3 months for the donor cells to start functioning completely. But it's very important to understand and talk to the patients about this, that even if you do everything perfectly, the most common cause of death after a transplant is relapse. So the dark black area is relapse. So if you look at the cause of death in autologous sibling or unrelated donor transplants, the commonest cause continues to be disease. It can take up to 2 to 3 months for the first 2 years donor cells to start functioning. Once you cross the 2-year threshold, the risk of relapse starts. So it's very important to understand and talk to the patients about this, that even if you do everything perfectly, this is the most common cause of death after a transplant is relapse. Only a patient, so the dark black area is relapse. So if you look at the cause of death in autologous, and we had good transplant recovery. So all of the patients had count recovery by day 11, day 12. 2 patients required ICU, and 0% patients had a mortality while undergoing a myeloma transplant. The most important part there was that the number of patients who were in CR, that is the orange part of the graph, that increased. So when you have only 35 patients in CR pre-transplant, almost 60% patients got CR post-transplant. So very, very important part of the treatment protocol, especially in the Indian settings, and a very cost-effective treatment method for our patients. And a PFS we got about 92%, and about 2 patients only died during this period. And it's important to also highlight that this is not a single department effort, this is a team effort. So pathology, microbiology, transfusion medicine, including the non-medical staff, because everything has to be maintained and checked regularly. So sanitation, electricity, air conditioning, HEPA filtration, water supply, everything has to be checked every day, and everything has to be made sure that there is no sources of infection in any of these sources. And hematology is at the bottom. All the other clinical departments are definitely indispensable for performing any kind of transplant. Nursing forms a backbone, so without good nurses it is not possible to do a transplant, because we are only in the unit for maybe twice a day doing rounds. The nurses are very, very important to identify early signs of worsening, early signs of sepsis, GVHD or any other problem. So nursing education and nursing involvement in the whole process and decision making is very, very essential for any PMT. And we are just completing a 50th transplant this week. Hopefully it will be discharged by this weekend. So it's just a result of team effort. Thank you, sir.
Thank you, Dr. Sudhir. This was a very nice presentation and very informative also. I just want to know, how do you separate stem cell from cord blood?
So cord blood actually, so we are not doing cord blood transplants here, and very few institutions in India actually are doing. So the thing is that I have never done a cord blood transplant, so I won't be able to give you the technical details. But it is mainly similar to a leukapheresis. So the positive selection of CD34 cells is done. So, but rather than that, I would like to highlight two things in cord blood transplant. That one, a single cord blood will not be enough for an adult. So if you are doing an adult transplant, you will need sources for 2 or 3 cord units at least. And second, the time taken for recovery in a cord blood is very high. The patient is inside neutropenic for at least 28 to 35 days, and that just dramatically increases the risk of infections. So it is very limited. It is mostly limited to children with inborn errors of metabolism or some other genetic diseases, but usually not preferred for any other disease. Yes. So cords are permissive for HLA mismatch.
First of all, Dr. Sudhir, I must congratulate you for the excellent work you are doing. Just wanted to know, well, I usually dealt with only adult cases. How do you decide whether you are taking a peripheral blood cell graft or whether you are taking it from marrow? Because marrow, by and large, if not peripheral is not indicated only, then we are doing from the marrow nowadays, isn't it?
So as a rule of thumb, marrow was indicated for non-malignant diseases, because when you take a bone marrow graft, the number of T cells is much lower than a peripheral blood, so the GVHT will be much lesser. So if you have a benign disease like aplastic or thalassemia or an inborn error of metabolism, where you don't need any GVHT, so you take a marrow graft. But in all other diseases, we need some element of GVHT to be present, so we always prefer a PPSC graft. But this also has a lot to do with practicality. So if you have, if the child is very small, you may not be able to get 500-600 ml of aspirate from the marrow, so we prefer a peripheral blood graft in that setting. So both these things have to be considered.
Now that you are into a very tough unit of a VMT, how you people are managing the, you have fellows, residents, because let us say you do a transplant, the patient has a engraftment syndrome. Now only you know it's an engraftment syndrome, unless or until you have a medico who has been trained like that.
Correct. So
and the patient goes into distress or he has a pleural effusion, only you know it is probably engraftment, or you are the earliest to judge when the VOD is going to occur, is it? So how are you managing the resident part of it? I think?
So resident part, I think, so we are highly reliant on nurses. So this is derived from all the older institutions in India, so Vellore and Tata. So they are, they have been doing transplant for 30-40 years, and they are very, very reliant on the nurses. So they have a separate nursing department for BMT. They have a nursing education program, nursing CME. So we have tried to replicate the same in our center. So our nurses have a regular teaching program, regular examination, presentations, because that is the only way you can pick up the earliest signs and symptoms of complication. Residents may be posted for a few days, but we don't have a constant resident posted inside. So nurses are the backbone of the process, and patient can anytime come to BMT post discharge and follow.
That is related to the cryopreservation, right? And in that they say that DMSO should be 10% actually. But what we are doing in the cryopreservation is that we are using 15%, right? So will it affect the viability of the stem cells if we do it like 10%?
So ratio is 10, all the studies say 10 to 15%, so I think we tend to give 15 rather than 10, and we've had good results with it.
And what are the most common side effects you encounter with the DMSO toxicity?
So DMSO mostly will cause some hypertension, so that is the most common thing we have to be aware of. So when we're infusing the cells, you have to have levitalol, amlodipine, everything available in the unit. Second important thing is ECG monitoring has to be there while infusing, because it can cause arrhythmias. Third, commonest thing you see is allergies. So patient will definitely have facial flushing, sore throat, coughing at that time. And the most important thing to follow up is hematuria. So they may have hemolysis on the day of transplant in the evening. They may have radicular urine, which may be very alarming. So we have to inform that to the patient. It's a very self-limited kind of thing. Settles in 1 or 2 days, but it is alarming, so we have to be aware.
Thank you.
Thank you, sir. I request the chairperson to please felicitate our speaker. I request Dr. Shabab and Dr. Manjinder to please come on stage to felicitate our chairpersons, please. Dr. Yogesh Arora. Dr. Sonia. And Dr. Sunny Jindal. Thank you all. With this, we come to the end of our Oncology Conclave. I would now request Dr. Kunal Jain to please give a vote of thanks.
Good afternoon, everyone. So, as they say, all good things come to a close. So, this is kind of the concluding part of our academic feast over the last 2 days, and this would not have been possible without untiring effects of our organizing team. So I'll, while I keep saying, I'll just request all the members of our team to please join me on stage. So I'll start with the surgery unit, the chief of our cancer center, Dr. Brad, Dr. Sumit Jain, Dr. Kunal Dhal, then my colleagues from Medical Oncology, Dr. Jagdeep, Dr. Nitish, who has just joined us, Dr. Suvir, and the Radiation Oncology team, Dr. Sandhya Sood, Dr. Ritu, Dr. Manjinder, Dr. Puneet Bhutani. Without him, we don't get any scan reports, so he is very vital. Dr. Neeraj, please. And Mr. Mishra also. Ajab. So all, I think it is always a challenge at the end of the meeting that more people will be on stage or in the audience. So good to see at least few people in the audience also. And I sincerely thank our administration, our secretary sir, who gave us permission to have this conference, all MAC members, our organizing team who has done such hard work in organizing this meeting. Then all the organizing team, local organizing team here, including Pushp and his co-workers who have been working for organizing the backstage things, and the people from media and print. And also I think special thanks to Indian team who lost the match in semi-final, so that people did not have any interest to watch cricket today, and they are sitting here, at least some of them are sitting here to attend the meeting. And last of all, God Almighty for showering His blessings on us. Thank you very much. Thanks, and please join us for dinner, lunch.
The lunch is ready outside.